I am going to show small video clippings of various types of metoplasties. Variations according to the canal size, be it in intact canal wall or in modified radical mastoidectomy. This is a case of tympanoplasty where I have done little bit of canalplasty and I felt that canal is very narrow and the meatus is not adequate. So I wanted to release. So I extended the corners flap incision at 12 o'clock superiorly, like how you give in the first part of the endoral incision. This will definitely widen the cartilaginous meatus. Again, I am keeping a big gel foam piece as a lining for the raw bone. So this also keeps the skin flaps away from each other. After that gel foam lining, I am keeping the wet gel foam and filling the external canal. Small merosil. Displays the flaps. This is a case where a small retraction is there into the attic, for which I have done wide canalplasty and I have to do ossiculoplasty, and now I am reconstructing the scutum. So this is the reshaped incus which I am keeping over the foot plate. A scutum reconstructed by the cartilage, anterior cartilage beam, posterior cartilage beam and inferior cartilage beam. Grafting is done with temporalis fascia, TM flap is repositioned and a cut. Good evening friends. In this video I am showing two. Good evening friends. In this video I am showing my metoplasty. Metoplasty is a reconstructive surgical procedure done for the widening of the cartilaginous part of the external canal, whereas canaloplasty is a procedure for widening of the bony external canal. In metoplasty, we will widen the cartilaginous part of the external canal by fashioning the flaps, where the much of the cartilaginous part is not removed. Metoplasty is broadly divided into two types, metoplasty and conchometoplasty. This metoplasty is done as an adjunctive procedure for canaloplasty, intact canal wall mastoidectomy or modified radical mastoidectomy with or without cavity obliteration. Whereas in conchometoplasty, we will remove a part of the conchal cartilage also to give extra widened external canal. The concept of metoplasty is about ventilation. For a good outcome of middle ear surgery or
ఈ arrow ఉన్నాయి కదా.
Good morning everyone. Harsha.
స్టార్ట్ చేసేయండి. వెల్కమ్ ఎవ్రీవన్ అని పెట్టేసేయండి.
ఇది క్లోజ్ చేయడం పడాలి.
ప్లేలిస్ట్ చెప్తున్నా కదా. ఇది ప్లేలిస్ట్ లో పెట్టారు దీంట్లో.
జూమ్ టు ఫిల్ లో పెట్టాలన్నమాట. జూమ్ టు ఫిల్
ఇది అంటే ఈ పైన ఐకాన్స్ కావాలి. వర్చువల్ పైన అది అప్లోడ్ చేస్తాం. ఇప్పుడు అన్ని ప్లేలిస్ట్ లో పెట్టాము. ఉన్నావు కదా, స్టార్ట్ చేసేద్దాం. మరి ఒకసారి నువ్వు కూడా వాయిస్లోకి వచ్చాయి. మేము కాస్ట్ చేస్తాం. ఒక నిమిషం లైన్లో ఉన్నాం. కాస్ట్ చేయండి. మాట్లాడే హర్ష, నువ్వు మ్యూట్లో ఉన్నావు.
Hello, sir. Good evening. Good morning.
Good morning, Harsha.
Yeah.
I think we are all set.
Yes,
Shall
sir.
we start?
Yes, sir. Please start.
I will start sharing my screen. Good morning, everyone. Welcome to this webinar, Chapter 5 of I Love Otology. So, in this webinar, I am going to share my surgical videos, edited ones. So, no live surgeries. Let us keep this more interactive. You can stop me or correct me at any moment. We shall discuss and see how this goes. I am sharing my screen. So for starting any program, we'll pray God. In this academic event, I feel teachers are our gods, and let us start by paying our respects to them. Harsha, am I audible? Is everything clear?
Yes, sir. Please go full screen, sir. Slideshow.
Yeah. Okay. So Dr. G.V.S. Rao sir, he is my mentor, teacher, my guru. He has taught me all surgical skills. I owe everything for him. As you all know, he is chairman of Rao's ENT International Hospital, Hyderabad. He has been delivering a lot of workshops, conferences, and sharing his knowledge for many budding ENT surgeons like me. So I thank sir for mentoring me or guiding me. My professors, Dr. S.V. Ramana sir, Dr. Veeranjanaylu sir, has been very kind enough to share their knowledge to me, and I'm very thankful for them for allowing me to join in their college and giving me the degree. Dr. G.S.N. Murthy sir, Dr. Bhimesh sir, Dr. Kumar sir have been very kind enough, and they are guiding me every moment. Whenever I am having some problem in the surgery, I used to call them. They used to correct me or guide me. Sir, I am very thankful to all of you, sir. My cochlear implant mentors, Dr. Subbarayadu sir, Dr. Krishna Kishore sir, who has made my dream come true. So ever since I joined an ENT, I want to become a cochlear implant surgeon. So Subbarayadu sir is very helpful to me for starting the program in my hospital. So we have been doing cochlear implants since 2011. So we are nearing 50 shortly. Thank you, sir. Dr. Krishna Kishore, sir, I am very thankful to him. He is also mentoring me and guiding me. Thank you, sir. And legends of AYAP, Dr. SK sir, JP Reddy sir, they have been teaching all postgraduates or many ENT surgeons like me through their conferences. In fact, SK Apparo sir has been our guest surgeon in one of my I Love Otology series, and JP Reddy sir also delivered important lectures in our last chapter 4. Dr. Balkiran sir, he is also my guru. He is very friendly and guiding me every time. Dr. V. Reddy sir, though is very senior to me, but he always he guides me with a friendly touch. He corrects me, and thank you, sir. And another legends of ENT, Dr. P.S.N. Murthy sir, the Durandar of AAP. He has been helping us and guiding us in all the academic events. We are lucky to have him in one of our workshop. He has come to our hospital and he has delivered lecture. And Dr. Rajbabu sir, he is the legend of Rajahmundry AYAP. He is also guiding and helping us whenever we meet. He used to guide all our juniors how to practice and what are the skills, how they used to develop in their days. It is really wonderful to talk to him. With this brief tribute to my teachers, we'll start the academic session. So for any surgery, we'll start with preoperative evaluation. For otological surgery, one second. When otological surgeries, in the preoperative evaluation, we'll have otological examination, be it V2 otoscopy or a speculum examination with a Bull's lamp or headlight. So in the era of endoscopes, video otoscopy plays an important role. I will show in one of our surgery videos how endoscopy will give the impact. So you can see a perforation, you can see some granulations, or there may be intact eardrum with fluid inside. There may be retraction with coexisting with perforation. It doesn't. It is not like that. Perforation will not coexist with retraction. In rare cases, they do coexist. You can even see ossicular necrosis. You can ask the patient to do Valsalva maneuver to know the eustachian tube function. In otological examination, nasal examination also plays a very important role. There may be coexisting DNS. One second. అంటే అది దానిలో నెట్ ఏమో స్లోగా ఉండాలి నా సిస్టమ్
ఇదమ్మా ఆప్టిమైజ్ ఫర్ టెస్ట్ రైట్. ఈ క్వశ్చన్ వచ్చింది చేసాం. కంటిన్యూ నెక్స్ట్ మార్చుకోండి.
అది ఇది So could you be able to see the screen? Yeah. So in otological examination, nasal examination also plays a very important role. You can't miss a diagnostic, you can't miss a nasal septal deviation. Sometimes there might be polyps, sometimes there might be adenoid, so obstructing the eustachian jugular phase. Mastoids being the topic of today's, so there is a great importance for the eustachian tube. So eustachian tube function is very important. For that reason, we will ask the patient to do Valsalva if there is any retraction, whether the eustachian tube is patent or not. Similarly, you have to do evaluate audiologically also. Butyron audiometry is a routine first step for all these things. Similarly, tuning forecast. Even without audiometry also, you will have some idea with tuning forecast. Most of the cases being mastoid being the topic of today's, will have conductive deafness. So whether the Renes is positive or negative, which side it is deviated, Weber's which side it is lateralized. With that knowledge, we can start the surgery. Butyron audiometry and impedance. In case of retraction, mostly our cases will be conductive deafness. In butyron audiometry, if there is a conductive deafness, depending upon the amount of AB gap, we'll understand whether it is only a perforation or any ossicular necrosis coexisting. So coming to radiological examination, so basic is X-ray temporal, X-ray both mastoids, but these days with the advent of CT scans, so I prefer a CT temporal bone for all the mastoid cases. There could be infection like mastoiditis, or there could be cholesteatoma. So how to differentiate a mastoiditis from a cholesteatoma? I think it is the subject of radiologist who can deal with this with the help of Hounsfield units. They will also comment about cholesteatoma if there is any erosion of the sputum or ossicles. So any invading disease may not be infection. That is the way they suggest as cholesteatoma. Sometimes a lot of infection, a lot of granulations, they are not responding for medical treatment. So it could be a tumor coexisting with infection also. So sometimes we'll also see tumors. So CT scan temporal bone will help us in ruling out all those things. And hematological, so this is routine for any surgery. So coming to the preparation, as for any other surgery, we'll take the consent and any specific consent for the surgery also. So this is mastoidectomy. So you'll ask the patient to know all the complications. Like you let them know all the complications. There could be tinnitus after surgery. There could be giddiness. There could be facial palsy, and the amount of hearing improvement may not be as normal as in a case of tympanoplasty, because there could be ossicular necrosis and there may be widening of the mastoid cavity. So all these things play a role, and patient should be well informed. Of course, if you tell a lot of complications, patient may not agree for the surgery, but at least for the documentation purpose, you should tell them to be on safe side. I prefer a dry ear before operating, but not responding ear discharge can be operated. Regular oral toileting is a must for achieving good results early. Not responding ear discharge, should always look for culture sensitivity. A swab for culture sensitivity is sent. In these days, with the advent of with increasing numbers of diabetes in patients. There is increasing incidence of malignant otitis section, which may turn into skull-base osteomyelitis if not treated early. So, early identification plays a crucial role in the management. If there are any granulations, you take a biopsy, whether it is granulation or tumor, will know. Diabetic status is very important. Unless it is controlled, you can't control the infection. And for clearing the granulations, it is not just antibiotic and Dexona soaked ear drops. Apple cider vinegar, commercially available, you can dilute it and ask the patient to instill the drops along with our protein ear drops. So acetic acid drops are also commercially available, but what I found is acetic acid commercial available drops are 1% and 2%. Sometimes they are not even responding with that 2% acetic acid drops. So I am asking the patients to apply the vinegar directly. Within a week, you believe me, all the granulations will subside. You can also use silver nitrate, copper sulfate, or take the patient to the OT, give some local, and do cautery. So, any points do you want to add in the preoperative evaluation or preparation of the patient? Anybody? So then we'll start the surgery. Okay. Before starting the surgery, let me introduce myself. I am Dr. Arun Kumar, ENT surgeon, Rajahmundry. I am practicing in Anjana Vaidyalayya Hospital. So let us start the surgery. This is a right ear. Usually we take 10 cc of local, 7 cc of distilled water, 7 cc of 2% xylocaine, and 3 cc of distilled water. In xylocaine, I prefer xylocard because that is preservative free, and you need not give any xylocaine test dose for that. So you can't rely on all nurses what they do. So in private practice, it is a must to be trouble free. So I prefer xylocard. So 7 cc of xylocard, 2%, and 3 cc of distilled water, and to that we'll add adrenaline drops, 4 drops to 6 drops for each 10 ml. మళ్ళీ మధ్యలో
వీడియో అంటే ఇప్పటివరకు మనం టెక్స్ట్ అనేది కూడా దానికి వెళ్ళిపోయాము. షేర్
అంటే మళ్ళీ మనం కొన్ని వస్తాయి వీడియో పీపీటీలు వస్తాయి అది చూద్దాం.
పీపీటీలో
మళ్ళీ దాంట్లోకి వెళ్దాం. So the needle should be, the beveled edge should be up, facing up, and we'll pass the needle through the post-auricular groove into the external canal, but not piercing the external canal skin. There will be a tenting, and we'll deposit the local there. That means we are infiltrating the posterior canal wall through the post-auricular groove. Here in the post-auricular groove, and we'll pass the needle towards superior wall, deposit something there, and towards the inferior wall. See how it goes. I'm passing the needle post-auricular groove. See the tenting. Yes, the bleb. See the post-medial wall is bulging. Similarly, into the artery canal. Now I'm depositing 4 to 5 liters, 4 to 5 ml of local in the post-auricular groove. You can just turn the needle without pulling it out. So far, I have deposited 5 ml. So before starting the case, we put betadine in the external artery canal. This is for asepsis. I use a slotted Tomarkin speculum. This slot will help us negotiate the instruments. See, this is the anterior meatal valve. Depositing 1 cc. You could see the markings of the syringe also. So 1, 2, and 3. So from 3 to 2, I will instill the local in the anterior meatal valve. So everything should be under vision. Now I'm infiltrating another 1 cc into the superior valve. Already we have created some bulge from the first pick itself. So that will allow the needle to go into the subperiosteal plane. See, again I am seeing from 2 to 1 cc into the superior valve. Now into the inferior valve or floor of the external artery canal. I am depositing the last 1 cc into the external artery canal. So far I have completed 8 cc. You can deposit the leftover in the post-oral region. After infiltration, you should give adequate time for the hemostasis to act. Usually, the adequate time is the bleeding time or clotting time of the patient. So roughly, if you can wait for 5 minutes, it is okay. Many surgeons give give infiltration first, and then they will go for the wash. By the time they will come after washing, and the patient also draping will be done, and by that time the infiltration will be in good effect. Okay, so now I want to talk about drilling techniques. So we'll have a handpiece, micromotor, and burrs. Depending upon the length of the burr, we'll have short burr, medium burr, long burr. Usually, the more the length of the burr, tends to wobble, and there will be less control over the burr. So ideally, a short burr is preferable, but you can't use a short burr in deeper structures. So for all superficial cuttings, for the cortical bone, you can use a short burr. I usually go with the short burr and a medium burr. Very rarely I use a long burr. There are various sizes available: conical burr, spherical burr, club shaped. Cylinder. So nature of the burr, it could be cutting burr, diamond, coarse diamond, and coarse cutting burrs. So these are regular micromotors. Most of the people use this basic micromotor, NSK or marathon. So very less maintenance among all the ENT gadgets which I have seen is this micromotor. It works for years or maybe for a life of the surgeon. Very low investment, high returns. But if you want to do any high-end surgeries like cochlear implant, where precision matters, you better go for brushless micromotor. The advantage is The moment you remove the foot from the pedal, it stops with 1 or 2 rotations. But in regular micromotor, it goes, the inertia of motion will be there and it goes for many turns. So coming to handpiece, this is a regular straight handpiece. This is the main workforce for any mastoid surgeon. So there will be contra-angle handpiece. If you want to work in post-superior region, if you want to drill in the for the stapes, if you feel your hand is obstructing the view, this contra-angle handpiece helps us. How to hold the handpiece? You should hold the handpiece like a pen. You should hold it at the tip. There will be grip, and don't hold it here or here. The more far you are, the less will be the control over the operating surface. So, like I said before, for superficial drilling, short and wide burr should be used. And in combination with it, you will have a number 4 section. See here, I am doing mastoid antrotomy. So, sister is irrigating. For the initial stage, I collect the bone pad, so there is less irrigation. If you don't want the bone pad, you will give copious irrigation. For deeper drillings, once you open the antrum or you want to widen it, then you can use a small burr. So deeper structures, you can't negotiate with a number 4 section. So you can have number 14 or number 16 section cannulas. If you want to use, if you want to clear the disease around the vital structures, like you want to remove the granulations around the stapes or the jugular bulb, anteriorly, if you want to remove, if you want to skeletonizing malleus, any tissues, if you want to handle, you can't use 14 or 16 section number. 18 number section cannula is optimum for that. That will give some traction, and the counter traction will be given with the curved pick. So how to drill? You hold the handpiece like a pen, and the stroke should be from dangerous situation to safe. That means from vital structures to the safe zone. If you are working around incus, so you start from medial to lateral, not from lateral to medial, like that. That is what I want to say. So if you are working over a facial nerve, you drill along the direction of the facial nerve. Don't do horizontal cuts. So even if you expose the facial nerve also, your strokes will be parallel to the nerve fiber. Okay. So known to unknown. So you are lost somewhere. So just zoom out. You'll find yourself and start drilling from the known area. So known to unknown. Always use the widest burr possible to the operating field. That means you should see 360 degrees of the burr. If you are feeling that you are drilling over the sputum, you should also see the other end of the burr. That means probably it is touching to the ossicles. If you are drilling in the additus, you should see that you are widening the additus anteriorly or laterally, but whether the burr is touching the lateral semicircular canal medially also you should check. And if you are doing a canalplasty, you should always protect the flap. So it is a saying that the axillary canal skin is like gold. So you should preserve it. So how to select a burr? Use the widest burr possible. If you are having a bigger work for a lot of bone drilling, use cutting burrs. They will save time and do the work fast. In cortical bone work, while doing antrotomy, there will not be any vital structures laterally. So you can use a wider conical burr that will cut fast, but you should always orient yourself. Don't do antrotomy with a closed or high zoom. So always make the in 0.6 magnification. See that you should see the axillary canal also in view. So long cutting burrs, if they can be used in a deeper bone work. If you are using if you are doing an osteoplasty, you want to do a socket, you should choose a burr bit. Roughly, I can say that if that burr bit, the head of the step is fits exactly to the size bore of the 18 number suction cannula. So you choose a burr bit that suits perfectly of the size of the 18 number suction cannula, and with that burr bit you can make a hole in the whatever it is. If you want to use a spur cartilage or a remnant ossicle, either most commonly it is an incus. So if you want to do a cochleostomy, it is 0.7 mm burr. Coming to skitter, it is a very valuable instrument. So it also avoids the hand coming to the field of operation, field of vision. Of course, it is very expensive. Like I said before, mastoid drilling comes in 3 segments. One is drilling, the other is irrigation, and the third is suction. It is a coordinated effort. It's a coordinated skill between these 3 actors. One is the surgeon, who is drilling with one hand and suctioning with the other hand, and the other is the assistant nurse, who is irrigating. So copious irrigation will prevent bone dust clogging the burr. At the same time, it also prevents heat generation. So what amount of irrigation must be there? The bone should not be heated, and it should not be like burnt like black or white. That color should not be done. So always the irrigation should be copious. I have the habit of collecting bone pit in the first stage itself. So at that time, I'll ask the sister to give less irrigation, and I will collect the bone pit. So always always take care of this word optimum. Anything is optimum, should be optimum. So it not be too much of irrigation, or it should not be too much of suction, too much less irrigation. So sometimes if the sister doesn't know how to assist, they'll put too much of irrigation. Too much of irrigation, what will do? It will lift the TM flap away, and it will make the TM flap come into the field of drilling. So to prevent flap floaters, we should optimize the irrigation. And too much of irrigation also obscures the vision. So you are working in a deeper structure. Lateral structures, cortical mastoidectomy, probably you may not be having that much of difficulty. But when you are operating around the near to the ossicles or operating over the facial nerve, definitely the field should not be obscured by the irrigation. So irrigation also depends upon the size of the burr. If it is a bigger burr, which generates more amount of bone dust, lot of irrigation. If it is a smaller burr with a small teeth, less irrigation is enough. If it is a diamond burr, it doesn't generate much bone dust, but it generates more heat. If it is a cutting burr, coarse cutting burr, conical burr, which I use for cortical mastoidectomy, probably I require a lot of copious irrigation. And where to irrigate? Irrigation is actually very difficult art. It is not the surgeon who is important. It is also the assistant nurse who is irrigating also makes the equally important role. The irrigation should be not exactly on the burr. Many people irrigate on the burr. What will do? There will be splash of irrigation. So that is very dangerous. So our water should come to the irrigating site. It could be just away from the drilling site, or probably at a higher level, so that the water will seep and flow towards the region of drilling. So just away from the drilling site, and regular, there should not be any gap between the irrigation to irrigation. Sister should load the syringe again. You should wait for the sister to come and irrigate. So if you can't wait and you continue drilling, there will be lot of heat generation and bone will be roasted. Similarly, suction. If you want high force, I suggest now what do you call it? 10 cc syringe, needle coming with the 10 cc syringe. You break the needle and you can irrigate. If you use a 14 number or 16 number suction cannula, water will not come with great force. So a wider bore needle will give it more force. And always the suction should be of wider bore than the irrigation cannula. If the irrigation is with an 18 number suction, if the irrigation is with a 18 number cannula, the suction should be 16 number or 14 number, or even 10 number, or number 4. So there should be a correspondence with the sizes of the irrigation cannula and the suction cannula also. So the irrigation and drilling techniques, this topic is completed. Anybody wants to add? Ravikant sir. Sir, are you there, sir?
మీరు చూడండి ఏం defect మీరు చూసేయండి. నెక్స్ట్
So ventilation pathways.
ఎక్స్ప్లెయినింగ్ లో చూడండి.
మనం ఎక్కడికి వచ్చా ముందు ఎక్కడికి వెళ్ళిపోవాలి.
నెక్స్ట్
I mentioned about ventilation pathways. So in otological surgery, ventilation pathways play a very important role, and they are very responsible for the outcome of the surgery. So for a successful middle ear work, ventilation pathway is very important. So middle ear cleft, it includes eustachian tube, middle ear, and mastoid. So ventilation from the eustachian tube reaches the middle ear. So there is always a mastoid buffer with a cellularity and helping in transmucosal gas exchange. So when the eustachian tube fails to equalize the pressure, there will be negative pressure in the middle ear, leading to atelectasis and sometimes developing into retraction pocket, which might even turn into adhesive otitis media or erosion of the ossicles or sputum, or at a later stage, even into cholesteatoma. These are some pictorial representations. There are various mucosal folds around the ossicles. The visualization of the ventilation pathway is difficult through the microscope in the middle ear surgeries. So you can use the help of a telescopes. With angle telescopes are better. 30 degrees is most commonly used telescope. We have anterior pathway and posterior pathway. The location lies anteriorly between the enclosed epididymal joint and the tensor tympani muscle tendon. It is the main and largest pathway route to the epitympanum. Like I said before, in the preoperative evaluation, you should ask the patient to do Valsalva. That means eustachian tube is patent or not. So this is the importance. In the posterior ventilation pathway, the location is situated behind the IS joint. So anterior to the IS joint is the anterior pathway, posterior to the IS joint is the posterior pathway. Posterior pathway is coming from the otitis and the mastoid. So a good cellularity of the mastoid allowing gases exchange and ventilation into the middle ear. So this is the anterior ventilation pathway. This is the posterior ventilation pathway. Malleus, incus, stapes. Okay, this is the middle ear photograph of the endoscope. Thank you. Next entry. PPT.
తీసుకోవాలి.
Okay, video కదా? Video. So we are going to the next video. So, chorda delineation. So, save the chorda. Good evening friends. In this video, I am going to show how to delineate chorda and how to prevent injury. In this video, I am showing two techniques of identification of the chorda tympani nerve. Identification of chorda is a very important step in tympanoplasty. While elevating the TM flap, after reaching the annulus, gently lift the annulus with a drum elevator or covered pick, whichever is convenient to you. See, we could see the annulus and the chorda. Annulus is a thick fibrous structure, while chorda tympani nerve is a slender nerve with vascularity over it. Identify the chorda posteriorly and delineate anteriorly till the neck of the malleus. As you all know, chorda tympani nerve is very much required for taste sensation. So it is our duty to identify and preserve the chorda tympani nerve. In retrograde delineation, in this unit annulus, here we start from lateral process of the malleus, identify it, skeletonize it, and identify the neck of the malleus, and from there we start delineating the chorda, and thereby we reach the annulus. So this is one of the case where we have done limited we have done canal wall mastoidectomy. Here this is the stapes and this is the chorda. I have removed the head of the malleus. So here also I preserved the chorda. So I am gently removing the granular TM attached to the chorda. It's a very slender nerve. Hope you could see the vasculature. This makes us differentiate between the annulus and the nerve. So let's start the mastoidectomy. Dear friends, in this video I am going to tell how to open mastoid antrum, most commonly called as antrotomy. Antrotomy differs from cortical mastoidectomy because in cortical mastoidectomy we have to excentrate all the cells in the mastoid, whereas in antrotomy we will just open the mastoid antrum, and if the mucosa appears healthy, we will leave it like this. After post-auricular incision, raise the musculoperiosteal flaps by giving a T-shaped incision and expose the mastoid cortex. Do antrotomy or raise the cornus flap and retract the pinna by passing a gauze piece through the pinna and reflect it anteriorly with a mastoid retractor. Mastoid antrum lies posterior superior to the bony axillary canal. So, most important landmarks are bony axillary canal, spina fenley, and supramastoid crest. First cut along the supramastoid crest, second cut along the posterior medial wall, and the third cut joining both these two. There should be copious amounts of irrigation. Use a wider burr possible. It can be conical burr or a spherical burr. Wash all the bone dust and you should always see the area you are drilling. It is always a good idea to collect bone paste. This bone paste can be used to cover the defect caused by any accidental injury to the tegment plate, sigmoid plate or any semicircular canals. Start drilling in the wider area. Identify the landmarks. Don't close the axillary canal with a cotton ball. Axillary canal gives a good idea about the depth of the mastoid antrum and its location. Here in the video, it is a lesser diameter will be shown, but in live I am seeing the axillary canal. The axillary canal will be here, and I will be watching everything. So in camera, will give lesser picture than what is going on in the live. Fish water test is positive, you need not drill towards the otitis. We finally close the post-oral incision in 2 layers or 1 layer depending upon the surgeon choice. So we have among us Dr. Subbarayadu sir. Sir Subbarayadu sir, do you want to? Sir, unmute sir. Sir, hello. 1 minute, sir. Or you can correct me. 1 minute, sir. 1 minute. Sir, 1 minute, sir. 2 minutes. Harsha, are you there? I don't know. Minus about. Sir, good morning, sir.
ఓకే. థ్యాంక్ యూ. సారీ ఇంటరప్ట్ చేశాను. ఆర్ యూ ఏబుల్ టు హియర్ మీ?
Yes, sir. We are able to hear you, sir.
Yes, yes. Thank you. Thank you. Very good. Wonderful initiation for the ABC of exploration.
Sir.
Just I would like to emphasize first one is you should understand about the embryological development of the mastoid to drill
Yes.
before it, because I
Yes.
have changed the drilling technique into modified way. There, then I can find out the embryological basis and anatomical basis for the drilling. As you said, the drilling of the cortex and also small correction between the aeration of the middle ear. It comes from the tubotympanic recess into four folds. These are the
Yes.
four sacs developed from the tubotympanic recess, not anterior and posterior like that. These are the
Okay.
sacus anticus, medius, posticus, and superior. Out of it, sacus superior and also posterior sacule of the medial sacus gives the development of the antrum. Antrum is the constant air cell. It presents since birth. The dimensions won't change birth to death, but the dimensions of the relations from the lateral cortex to the medial only varies. The size of the antrum is since to death is the same size, around 4 into 4 into 4 mm. The drilling part, like that, you have to develop. The medial part is developed by the posterior cycle of the medial sacus, and also the lateral antrum developed by the superior sacus. That's why the drilling I have started from the tip of the mastoid. That is the basis for that. That only correction. And also here, while elevating the tympanic membrane, you should emphasize that the weakest point of the annulus, tympanic annulus. Where is it weakest? In the right side tympanic membrane, the 9 o'clock, the 3 o'clock is the weakest part, where you can push the temporometal flap anteriorly with the cotton ball. You can easily see the chorda tympani. It comes out easily. It's pop out from the annulus. Why? Because the shape of the annulus varies from superiorly downwards and also again anteriorly. Is usually it's U-shaped. Where in the right side is at the 3 o'clock position and the left side at the 9 o'clock position is a C-shaped. It's the sulcus easily comes out from that area. There only the chorda tympani sits. That's why you have to take care of that one. You have to laterally, that's medially push the chorda tympani while elevating the membrane, and also laterally push the temporometal flap. These are the 2 points I want to add here. And also the suction and also the burr parts. You should know so many things about the flukes of the burr, shapes of the burr, direction of the flukes. These will depend the cutting area. While you take the smaller flukes, it takes the more bone from the cortex, and also it causes more trauma and bleeding area. If you go for the number of flukes is more, it sometimes acts as a diamond burr also. That's why the direction of the flukes, angle of the flukes, number of flukes may play while drilling it. And also while doing at the mastoid cortex, always take the short burrs and also the wider burrs, as you say. And going to the deeper areas, one thing you mentioned, unknown known area to unknown area. That is not correct. You have to go from known area first. You can go the known area from unknown area first, and also always medial to lateral. Like that, we have to identify the structure. You should not go the unidentified structure. Those are the points I want to add. Furthermore, later on I will add something. Thank you.
Thank you, sir. Thank you, sir.
Continue, Emma. You can continue the lecture in between.
Yes, sir. Yes, sir. So we'll start with the cortical mastoidectomy, the first exercise in mastoidectomy. So this is a surgical video. The patient is complaining of left ear discharge and is having a tinnitus. Sometimes the patient history also will be misleading. They will say 1 month or 2 months, but you have to assess whether it really 2 months or more than 3 months. So this is the Putin audiometry showing a big AB gap. the HRCT temporal bone, suggesting soft tissue areas in the mastoid antrum. So I'll start with cortical mastoidectomy. A horizontal incision in the external canal at the junction of the bony cartilaginous junction. Cornus flap is elevated with a round knife. Post-oral incision is given from the mastoid tip to the superior part of the pinna. T-shaped incision is given and musculoperiosteal flaps elevated. Here,
Arun, good morning.
before keep passing a ribbon gauze, you should. Sir, good morning, sir.
Good morning, Jason Murthy here. Only one
Sir,
minute.
Sir, good morning, sir. GSN Murthy, sir.
Morning. Do you give a corneal flap in all the cases? Do you do? What is the advantage?
Sir?
Can you hear me?
Yes, sir. I can hear you, sir.
Okay, in all the cases, do you do corneal flap? What is the advantage of it than just cutting posteriorly?
Sir, in all cases, I do corner flap, sir.
Yeah.
The advantage I felt is the margins will be more regular in corner flap. So
Okay.
here we'll take the horizontal cut and we'll give a superior cut and inferior cut. If you do posterior tympanotomy, you'll pass the blade from here and you'll give a stab and you'll give a, it will be the corner flap. Most of in both the cases we'll have some post-meatal skin flap. In corner flap, we'll get a box-like thing. In a post-meatal we'll get a U-shaped tongue. So that is one point.
Coming out,
other thing is
so the
while raising
approximation of
corner
the two
flap,
flaps
we'll
will
go
be very
more
good.
medially. Sir?
No. When you're in the end of the case, when you're trying to oppose both the temporometer flap and the corneal flap, that will be very good when you do a corneal flap. It will be very advantage. There will not be any gap between the two things, and there will not be any post of granulations.
Yes, sir. Yes, sir.
In some cases, when you do posteriorly, when you stab into the external canal, there may be some space between the temporometer flap edge and this flap. So it may give some granulations in the post-operative to keep some troubles going on always. So I feel also it's always better to take even if it take you 5 to 10 minutes, it's better to start with a corneal flap than doing a posterior metoplasty.
Yes, sir. Yes, sir. While closing, we should see that both the flaps will approximate TM flap and the corner flap. And I prefer a two-layered suturing. In that, the first layer which we use suture for the musculoperiosteal flap, so we should take at the proper level the first bite. So that will give good amount of corner flap hanging into the external canal.
Yes.
If you take it a bite at the lower level, the corner flap will be pulled away from the TM flap. So there will be some gap.
There could be fistula from the external canal to mastoid also.
Yes, sir. Yes, sir. Yes, sir. In one of the case, I will show the suturing also, and then how to avoid myotoantral fistula in such cases.
Okay.
Sir.
Okay, sir. Thank you.
Corner flap is elevated with a round knife. Post-oral incision is given from the mastoid tip to the superior part of the pinna. T-shaped incision is given and musculoperiosteal flaps elevated. Here, what I am about to say is, so after releasing the corner flap from the bony meatal wall, you should give release incisions. You should give release incisions from here to till the anterior wall of the external canal, superiorly, and similarly you should release inferiorly also. If you don't release and apply the ribbon gauze, that will pull the TM flap and it will make the TM flap tear. You don't understand how this tear occurred. So if you don't release and you pull it, then tear will be happening. Given and musculoperiosteal flaps elevated. See, for any tympanosoplasty or mastoidectomy, you should always see this should be the exposure. Anterior buttress till the post buttress. B to B should be the exposure. It is not 12 o'clock to 6 o'clock. External canal incisions are given superiorly from 10 o'clock to 12 o'clock. And similarly, TM flap elevation also not between 12 o'clock and 6 o'clock. We'll give external canal incisions, and this is the left ear 12 o'clock, this is 10 o'clock. Similarly, this is 6 o'clock and this is 8 o'clock. So superior flap from 10 o'clock to 12 o'clock and inferior flap from 8 o'clock to 6 o'clock. So here the superiorly the flap will be thick, maybe because of infiltration also it becomes swollen and it becomes thick. The vision towards the scutum or Prusac spaces or towards attic, whatever you call, that region will be obscured by the edema of the superior flap. So it is a routine habit for me to trim this superior flap. And inferior from 8 o'clock to 6 o'clock in the case of left ear. Superior flap is trimmed to give good exposure to the region of Prusac space or scutum. Now after getting good exposure of the external canal, the margins of the perforation are trimmed along with excision of the part of the middle ear polyp. So the entire polyp has been excised along with the margins of the perforation. TM flap elevated with a round knife or a flag knife. Spine of Henle identified and the triangular of attack boundaries are defined. First cut will be along the supramastoid crest, second cut will be along the posterior medial wall, and the third cut will be joining both these two. It is always advisable to make the mastoid antrotomy as wide as possible to prevent any injury to the vital structures. I generally don't keep any cotton plug in the external canal. I keep external canal always as a reference point. While watching the external canal, you will know what is the depth of the mastoid antrum. Roughly, it corresponds to the depth of the middle ear. I usually collect bone pad. See, always the external canal should be under vision. Don't keep a cotton plug here and do the drilling. It doesn't matter even if bone dust enters into the middle ear. You can wash everything. If at all any vital structures found decent, I use the bone paste to cover them. Water is not coming into the middle ear means the adhesive is blocked. We have to drill little bit more towards the zygoma and clear any edematous mucosa. Here, there is, if you are opening the antrum, if you open the antrum here, you'll always have the chance to widen anteriorly. And if you want, you also have a chance to do canaloplasty. If you open here, you don't have the chance to do canaloplasty. Small depression noted in the inferior floor of the external canal. So that is taken care of, and the canal wall is smoothened and regularized is elevated with by the canaloplasty. Post-oral incision is given from the mastoid conical slender burr superior part of the pinna. T-shaped incision is given and must for this purpose. Annulus gently elevated from the posterior superior quadrant, taking care about the not to injure the chorda tympani nerve. The annulus is then elevated from the sulcus under vision. This is the advantage of canaloplasty. See, there might be many people who are against to canaloplasty. So my view is you should always do any surgery under vision. So you can do annulus under vision only. You should elevate the annulus under vision. So for this, you can tilt the head of the patient or tilt the table of the patient, or you can tilt your microscope and you twist your back so that you can see the annulus, or you can use an endoscope. Endoscope will give a closer view and you can do this thing. So all these are various measures and you can do whatever you want at your convenience. So these are various techniques described and the surgeon is at his discretion which technique to use. So after removing this part of the bony shelf, we could see the annulus and we are elevating. Because if suppose you are leaving annulus here and you are grafting lateral to it, that means you are leaving the epithelial rest medial to the graft. So that is the reason why I am stressing on bone canalplasty. And superiorly up to 10 o'clock. So now I am doing post-superior canalplasty, and so that I can regularize the canal shape and also I could see the ossicular continuity. Most of the bone part is drilled, leaving a small eggshell bone over the chorda tympani and over the ossicles. This part is chipped away with the curette. Now you could see a lot of edematous mucosa or granulations obscuring the vision of the ossicles. These are gently cleared by using a curved pick. The strokes of the curved pick should be in the line of the important structures. Now I am drilling towards the zygoma. So my anterior limit will be short process of the incus delineated, and gently a small curved pick is passed below the short process of the incus and any mucosa or granulations cleared. Round window reflex checked and ossicular mobility also checked. Now you could see that the meatus is patent and water is freely flowing from the mastoid antrum to the middle ear. Now Hugo fish water test is positive. Edematous mucosa near the opening of the eustachian tubal orifice also cleared. One wet gel foam piece is plugged into the eustachian tubal orifice and a small conchal cartilage. See here, whatever I have told in before. So anterior ventilation pathway through the eustachian tube is established by clearing the edematous mucosa, and similarly through the adhesive also is cleared by drilling towards the zygoma through the antrum and also by doing post-superior bony drilling. So ventilation is established, any granulations removed, and patency is established. And the next thing is ossicular continuity also checked, and similarly chorda is preserved. So ossicles preserved, chorda preserved, ventilation pathways established. This is the key for surgical outcome. Harvested is kept as an anterior cartilage beam lateral to the eustachian tubal orifice. Temporalis fascia is gently maneuvered through the axillary canal into the middle ear to do an underlay grafting. Anterior and posterior flaps are overlapped and double breasting of the grafting is done. The gel foam sticker is gently wiped all around the margins. This is called gel foam mopping. This will enable us to see whether the graft is stuck conveniently and comfortably all around or not. Small dry gel foam pieces are placed first around the margins and later all around the. As I told before, optimum, this word is very important. So the amount of gel foam packed in the middle ear should be optimum. If it is too less, the graft will fall medially and it will not stick to the TM flap. If it is too much, it will bulge. So in lateralizing of the malleus, we'll pass the graft medial to the malleus and this dip will be there. This is the umbo region and there will be little bit of bulging. This bulging helps in making the graft stick or close to the TM flap. So all around you will pass the dry gel foam pieces that will absorb any traces of blood, and they will make both these tissues stick together. Graft, so that this will make the eardrum in proper orientation. It's called gel foam tiling. Now small gel foam pieces are placed all along the walls of the axillary canal to keep the canal skin in approximation to the bony canal wall, called gel foam lining. So in cortical mastoidectomy, this is a basic one for which we have adhesive block in view of, like with granulations. Now this is another place where we have adhesive otitis media. Good evening friends. In this video I am showing how to manage a case of adhesive otitis media. Here you notice that this is not just a perforation. So sometimes we feel that this is a perforation, but in examination under microscope or a telescope, it will give us more insight about the color and texture of this region. If it is pinkish, it is middle ear, but here it is whitish, fairly white. That means the eardrum has draped along the perforation and it is draping over to the promontory. This is an atelectatic eardrum. So that retracted part will get thinned out in due course of time and it will become adherent to the promontory. So all these, when you excise, in the last case also we have excised the granular part of this thing. So that will leave a raw area over the promontory. This cartilage beams concept is like a poor man's friend. Initially we used to keep silastic sheet in the middle ear to prevent the synechia, and we have to remove the silastic sheet in a second sitting. These cartilage beams will avoid that necessity to do a second relook operation. So this cartilage is easily available from the same place, pinna, and you can keep it one here and one posteriorly. The anterior cartilage beam will lie, this beam will lie above the opening of the eustachian tubal orifice. Thereby, it will not prevent or obstruct the anterior ventilation pathway. But at the same time, it will give strength to the TM flap and the graft assembly anteriorly. Similarly, in posterior cartilage beam, it will give support posteriorly, and it also helps us preventing any retraction. Excising the margins of the perforation along with the synechia. See here, identify, see how my curved pick is doing. I am keeping the curved pick laterally so that at the same time I am freshening the margins, and at the same time I am making the undersurface of the TM raw. So you don't see two steps. If you keep the curved pick laterally, you will do both the steps in one go. This is the retracted eardrum. This is the anterior annulus to the promontory mucosa. See, these are all cartilage beams. They are floating beams. They will take the support with the eardrum. They will get attached to the eardrum and they will be staying there. So initially, before the cartilage beams taken up by the graft, will have the gel foam support for the 2 to 3 months. And after that, the middle ear will be empty and the graft will, the cartilage piece sticks to the eardrum. And you can see in my post-operative videos also, you'll see clearly the cartilage pieces. This is a small modification of the cartilage tympanoplasty. So in the where I'm avoiding a cartilage shield graft in the middle, because eardrum should be vibrating. A thick cartilage piece or a big shield graft will reduce the vibrations of the eardrum. So I am avoiding the cartilage piece in this region, and I am placing one anteriorly and one posteriorly depending upon the situation. can post your comments or questions in the chat box so that I will answer them even while doing the lecture. All the Seneca released. Now I am giving extended canal incision. See, if you give a good block, if the infiltration is proper, if it is going into subperiosteal plane, the field will be like this. So I will give only 10 cc of local and I will give only once. There is no need to give second infiltration also. Even in some cases where the intraoperative BP shoot up to 180 to 140, even then also the field will be like this. So in between lectures, I will answer the questions raised in the chat box. Annulus delineated and TM flap elevated. In chronic infection, there might be some tympanosclerotic blocks also. Any unhealthy eardrum can be excised. So this looks like some idea about the area which you are operating. Here, this is the malleus lateral process. This is the area of stapes. So you are trying to clear the TM flap. At the same time, you should also look at the curved peak tip, whether it is touching the stapes or any other vital structures. Yes, but later I found that this is a synechia from the tympanic membrane to the promontory mucosa. Be vigilant about the vital structures. I am skeletonizing the malleus. Ossicles found intact. All the Seneca released. Usually, a shield graft is preferred here in this situation to prevent recurrence of synechia. But in this context, I will stress upon my cartilage beams concept, wherein a cartilage beam is kept anteriorly and posteriorly, and the graft is adjusted so that it is perfectly fitted to a frame, and there is no chance of any synechia. size of the fungal cartilage piece also can be decided before harvesting itself, so that you can harvest exactly the required size. And it is also easy to harvest the conchal cartilage there itself. Fill the pinna like your chopping board and cut the if you feel it is thick, you can slice it. Anterior cartilage beam placed and dry gel foam is passed underneath it, so that it rises above the level of the eustachian tubal orifice and the eustachian tube ventilation pathway is not at all blocked. Posterior cartilage beam is also placed. Graft is adjusted and you could see that the temporalis fascia is well spread and fixed to a frame. Dry gel foam pieces are kept in the external artery canal and the TM flap and the graft assembly is fixed in a perfect orientation. Thanks for watching. Yes, we'll take some questions. So, one doctor is asking, have you experienced severe granulation reaction and fibrous if the cartilage is placed in the middle ear? No, there won't be any granulations because everything is covered. If you keep the cartilage exposed, they'll take time for it to get the covering, skin covering. So at that time, granulations will appear. If you cover the granulations, there won't be any. If they cover the cartilage, there won't be any chance of granulations. And in the middle ear also, I never experienced any fibrous tissue because the healing is good. And you don't believe, even you could see that the graft is perfectly fitted to some frame like thing. It will be in good orientation. And in revision tympanoplasty where cartilage was placed in first surgery. So I'll see the cartilages in revision cases. I'll see the cartilages, but they are all good, and you can reuse them also. Any more?
Hello.
Sir. Good morning, sir.
Good morning, Arun. Very nice demonstration of the technique.
Thank you, sir. Thank you.
Very good. Because cartilage works very well for this kind of cases. Yes,
Sir.
I have been doing this technique for the past more than 25 years, this kind of
Yes, sir.
cartilage supporting. Particularly what you
Yes, sir.
kept as a support towards the eustachian tube in the anterior region. And another thing, along the slope of the posterior canal, what you have drilled. These two
Yes,
things will definitely the wonderful support. Because these cases, what you are doing for atacantral disease, mostly,
Yes, sir.
if it is a tubotympanic, you won't do in this kind of cartilage reconstructions. It's only in
Yes,
the atacantral disease, which are usually resulting from a eustachian tubal dysfunction or some sort of chronic negative pressure in the middle ear. So the cartilage will give you a lot of support in and the future retractions or any recurrence of pockets and all those things. Anyway, good work. Please keep on,
Sir,
keep going. Yeah.
Thank you, sir. Thank you, sir. Thanks for joining us, sir. Sir,
Yeah,
please,
welcome.
at any time you feel I'm not giving proper suggestion, please
Okay.
correct me.
Yeah. I will
Yes,
be.
sir.
I will be
Yes.
interacting. Yeah.
Thank you,
Okay.
sir. Thank you, sir.
Yeah. Welcome.
Sir, the next video is any other question?
Sir, Dr. Rani is asking how to minimize or avoid numbness in upper part of the pinna
Okay.
post-operative.
So we'll give cuts in the post-oral region, and we'll also giving cut in the musculoparietal T-shape incision. Definitely, we are cutting the sensory supply to the post-auricular region. So these will take time for the nerves to renervate, and so maybe 3 to 6 months. I advise I'll tell the patients that you may have numbness. Some people complain like for the same like pain. So this is generally a numbness, and it will stay for 3 to 6 months. And I'll advise them B12 tablet, so that will help in good early recovery of the numbness. And also, I try to minimize the cautery. A good hemostasis and giving good time for the infiltration to act, there will be less bleeding and there will be less use of cautery. And also the post-oral T-shape incision, musculoparietal incision also, I will give with a 15 blade. And I will cauterize only those bleeding points. Thereby, I am minimizing the cautery there also. So minimize cautery, give good time for the hemostasis to work, and supplement with a B12 tablet. So I think these three will be enough. Sir, any other, sir? Want to add anything more? How to avoid pinna numbness? Regarding eustachian tube balloon tuboplasty, somebody asking, I'm not having any experience in eustachian tuboplasty. But so far, as we check with Valsalva and we also do the flushing, so far I think they are good. The next will be an intact canal wall mastoidectomy with a limited cholesteatoma in the attic. See, I have done cortical mastoidectomy. So in a while dealing a cholesteatoma case, there are 2 to 3 patterns. One pattern is you open the antrum, you'll see where the cholesteatoma is, and then look for the attic. First antrum, then attic, and do atticotomy along with a canalplasty. That is one type of intact canal wall. The other thing is you start with attic and canalplasty in the initial day itself. You follow the sac, and once you feel that you have gone beyond the sac, and still you have some post-bony metal wall, you stop there and open the antrum next. Similarly, in MRM also, you can start from anterior buttress to posterior buttress. That means inside out. And the other thing is C technique. You start from lateral to medial. So these are various techniques and various ways to do mastoidectomy and approach the So our main concept is middle ear ventilation is of prime importance. So one delegate is asking, what if adenoid is enlarged? If you are feeling it is a big adenoid, you should operate. So first I mentioned about diagnostic nasal endoscopy, where you should look for adenoids or any nasal lesion, any nasal pathology. If you feel it is contributing to the ear, definitely you should address the adenoids. If it is small adenoid and is an adult patient, you need not do adenoidectomy. But if it is a pediatric patient, he is having cholesteatoma, definitely you should address the adenoid. So here I have done antrotomy first, and then I am looking for cholesteatoma. So I am just doing the canalplasty. Along with that, I'll go for the atticotomy. Like I said before, initially I used a bigger conical burr for the lateral part. Then I am going for a slender burr for a deeper part. As I am reaching towards the ossicles, I am using a small spherical burr. So depending upon the situation, you should change the burrs. Not just the size, you can also, if you are still over the narrow, something like that in this posterior superior quadrant, maybe you can go for diamond burr. So one delegate is asking when to go for diamond burr. If you are near to the important structures like tegmen or any nerve or ossicles, you should change to diamond. Here we have identified a cholesteatoma sac, but that is not in the antrum. So it is just up to the level of the adductors. So I am taking bigger cotton ball and pushing the entire cholesteatoma sac from mastoid antrum into the attic. This cotton ball dissection is a very useful technique. It will clear most of the cholesteatoma sac into the attic. But at the same time, it is not 100% foolproof. So what I am doing is, I am taking a flag knife and I am rubbing the medial surface of the mastoid or attic with a cotton ball, so that I am clearing all the granulations or any other remnant epithelial layers. So after disease clearance, the mastoid bone should be epithelial like a pearly white. This I call as marbling of the mastoid. So if you leave if you attain this stage, there won't be any granulations, and the mastoidectomy case heals very fast. You don't even require 3 months. It completely heals in 3 weeks itself. Here I am using a dry gel foam base to clear the granulations around the tape.
Arun,
Sir.
how do
Yes,
you
sir.
decide whether you are going to simple mastoidectomy and see further,
Sir,
or you are going
preoperative
from the
evaluation.
attic and posteriorly?
Sir, preoperative evaluation, sir. So with a prior CT scan of the temporal bone, we'll have some
You advise
idea
CT
about.
scan for all the cholesteatomas?
Yes, sir. 100%, sir.
Okay. So it's a must.
It's a must, sir. Yes, sir. For
Depending
the
on the
reason
CT findings, you will decide whether you are going from atticotomy and backwards or starting with the simple mastoidectomy.
yes, sir.
Clinically, after opening, how do you decide?
CT scan not only gives the idea of the extent of the disease of the granulations or cholesteatoma, it also gives an important idea about the ossicular status. So whether to do wall down or whether to do control or whether to how carefully we have to go, we'll know whether the incus is in continuity with the stapes. If there is ossicular necrosis, right away you can drill the bridge if it is required. So how careful you are to be, what are the regions you should be drilling slowly. So that information also we get from the CT scan. And the third thing is, we will also
Good afternoon.
about the plan of action. If it is limited to only the attic, so we will plan atticotomy along with canalplasty. If it is extending into the mastoid, we will do a wall down. For me, if it is a cholesteatoma, most of the times I will do wall down procedure, because many a times I have done intact canal wall cases. Maybe after 10 years, they have come with some recurrence. So to prevent recurrences, or if it is a revision case, I do wall down procedure. And I'll ask the patient to come for every 3 to 6 months, depending upon their convenience, so that if any oral toileting should be done, we can do. And also, the ear will be under constant surveillance. Sir, okay, sir?
Sir, Murthy sir, good morning. Hello. Hello. Murthy garu. Arun.
Sir. Yes, sir.
I want to add, Sara is asking for CT scan now. Nowadays,
Yes,
we
sir.
have
Yes,
to
sir.
habituate the juniors for any kind of case. It's better to go for CT scan, CT temporal.
Yes. Yes, sir.
It
Yes, sir.
also avoids so many medical legal issues and also the insurance issues. Sometimes
Yes,
when we
sir.
expect a simple disease, it may turn into the major disease.
Yes, sir.
That's why now the CT scan also not costlier nowadays. It's better to habituate take the CT scan prior to the surgery to know the anatomy and also to predict the outcomes and also the surgical roadmap for to do the surgeries, even the junior surgeons.
Yes,
Why?
sir.
Because the treatment patterns and also management by the so many levels, the disease pattern will change everything. If you see the small perforation, also sometimes you are surprisingly seeing the cholesteatoma and the mastoid. That's why always better to go for HRCT and also the experienced radiologist or share with your seniors but to come to a conclusion prior to the surgery. That is my personal opinion.
Yes, right. I agree with you. You definitely should take a CT scan for all these cases of a suspected cholesteatoma or a chronic CSOM or a wet ear, in fact. Medical legal purpose and for our planning of the surgery and to avoid complications also.
And also other thing, monetary side, insurance companies also asking why are you make this surgery, that surgery, they are not sanctioning the amount properly also. The clear evidence, we can fight any level.
Arun, when you're doing
Yes, sir.
antrotomy initially for a cholesteatoma, first do you check
Sir.
the ossicular status and the continuity of the infrastibial joint?
Yes, sir. Yes, sir.
You should
Because we
dislocate
are
that, then
working
only
in a,
should go for an antrotomy.
yes, sir. We are working in a, sir, in this case, hope we could see the cursor moving. So this is the external canal size.
Yeah.
This is the extent of the, this is extent into the attic. So we are working in a very narrow area. So it is always better to do a canalplasty along with atticotomy. So we'll do the attic work and also the canalplasty work. This will make the field, operating field wider, and also it will avoid complications to the touching the ossicles.
Yeah,
So
you can see the IS joint also.
yes, sir. We'll see. Like I said before, you use a conical burr. Sir, you gifted me one slender conical burr. I'm using it for all my canalplasty work. I'll delegate all my canalplasty work to you.
Okay.
Sir. So we'll drill the lateral part and we'll leave a small shell of bone near the chorda or the IS joint.
Yes.
And from there, we'll chip it off and see the ossicular status. Then we'll go wild.
To the attic. Fine.
Yes, sir.
Right. Thank you.
See, this is the final result after closing. So as if here I have put one conchal cartilage that is exactly fitting to the anterior wall and posterior wall of the attic. So the size of the cartilage or cartilage buttress should be exactly fitting, and the graft should go smoothly. So from here it is going to the cartilage as if it is all one surface, and anteriorly it should rise to the anterior wall, inferiorly to the floor and into the post-medial wall. Cartilage beams placed also here anteriorly and posteriorly, they are acting like a frame. The eardrum is perfectly stretched with the malleus over it. So if you have like this, there won't be any granulations over the cartilages and the cartilages will not be extruded. You always take care that the muscle flaps or cartilages, whichever you put, should be covered with a temporalis fascia. So with this, we concluded the atticotomy for limited cholesteatoma. And also here I pushed the cholesteatoma sac from antrum into the attic with a big cotton ball. sometimes what I feel is, if I am not happy, if I am not confident that I am leaving some remnant here, I will drill the inferior margin with a diamond burr. So here there will be short process of the incus. This fossa incudis is also a good culprit. It hides some epithelial rest. So here will be the lateral semicircular canal. So we'll drill the upper margin, taking care not to injure the lateral semicircular canal, and we'll drill the fossa incudis, taking care not to hit the second genu. So this is a very narrow and crucial space. Anteriorly will have the IS joint, or medially will be the facial nerve, horizontal, and the second genu. Little bit posterior superiorly will be the lateral semicircular canal.
Arun, can
Sir.
I add a point?
Yes, sir. Yes, sir.
Here we are talking about the canal wall up for the cholesteatoma.
Yes, sir.
As you said, canal wall down is the definitely the final answer for any aggressive cholesteatoma. But the cholesteatoma, when the cholesteatoma is very limited, not much of extension, and particularly it is a thick-walled cholesteatoma. Thick-walled cholesteatomas are surgeon-friendly. It is a thin-walled cholesteatoma. It creeps in different directions into multiple cells. The thin-walled cholesteatomas are really troublesome situations, you know. A thick-walled cholesteatoma can be easily dissected out, and you are sure that you are in continuity, you are excluding all the cholesteatoma. But the point here, what I want to just mention is, when we are doing the canal up technique for cholesteatoma, as you said, a good canalplasty combined with a transcanal attecotomy that gives the exposure. Then you are going to perform a good cortical mastoidectomy, and that cortical mastoidectomy is going to continue towards the aortic as epitympanotomy.
Yes, sir.
A very good epitympanotomy you have to perform, by which the epitympanotomy should be able to show you the head of malleus, not only head of malleus, anterior to the head of malleus, that is anterior aortic. So up to the anterior aortic, you can get very good exposure by doing a transmastoid epitympanotomy.
Yes,
so
sir.
these three procedures combined, that is, 1 canalplasty, 2 transcanal attecotomy, 3 transmastoid epitympanotomy. All these things put together should give you a very good exposure of the entire cholesteatoma sac, overall, the aortic, the posterior tympanum, the antrum part, everything, and see that you are dissecting of the sac in continuity, that you will get a very good outcome, even with the canal wall up technique. Okay, thank you.
Yes, sir. Yes.
Kishore.
As you said, the thick-walled cholesteatoma sac comes like a pearl.
1 minute, Arun.
Yes, sir.
Arun.
Hello, hi, Murthy.
Hello.
Hello, it's Murthy.
Can you hear me, Arun?
Yes, sir.
Hello.
Sir. Sir is interacting with you, sir. Please go ahead, sir.
Yeah, as Kishore said, a good canalplasty with a good attecotomy and including the anterior aortic space also definitely will give you a good exposure and can clear the cholesteatoma. As you said, a totally thin sac cholesteatoma which will infiltrating all the cells, or a thick sac cholesteatoma, which is a very well-behaved cholesteatoma they call. Well-behaved cholesteatoma can be separated from the surrounding area and can be cleanly taken out from the mastoid and the attic also. But as we have discussed previously also, Arun and Kishore, whoever may be doing it, at the eventually after maybe 5 years, 10 years in the timeline, definitely we are getting the recurrences. So as Arun has opinioned it, nowadays I am again turning back to MRM in all cases of cholesteatomas. Of course, unless it's very much limited to attic and additus or up to the antrum only, which has touched the antrum, I am going for MRM only. Because having seen from the last 30 years, whatever you do, these all retraction disease cholesteatomas are definitely recurring if you are doing a canal wall up. What is your opinion, Arun?
Sir, it is better to do wall-down procedure, sir. One word answer. Sir, one doctor is asking, will you counsel the patients for second stage? So second stage, second surgery, we can't.
This is India.
No patient will agree.
Can't afford.
So, so it is always one surgery and one go.
Yes.
So by textbook, we should do osteoplasty in second stage. But given to our circumstances, we are doing osteoplasty in the same sitting. And regarding the size of the external canal, if we in some cases which I have done without doing canal plasty, that means the size of the external canal is of this size, and I have done epicotomy. So if we are doing in a narrow space, the recurrences are more. In cases where I have done epicotomy along with canal plasty, the recurrences are less. So Rao sir, what he says is the canal should be regular, even if it is external canal, or this will become the new external canal. The entire epicotomy along with the canal plasty, he will do that in one go, so that the canal will be looking very regular, round, and the patient will
It's
not
a very
feel
bigger.
any.
It's a bigger external canal.
Little bit, sir. We will partly close the scutum also, will reconstruct, and the external canal also, this thing also will be there. It is not of much difference. Little bit bigger than the before.
Sir, one more addition regarding the revision surgeries. Nowadays, everyone having the intelligence of perplexity and also ChatGPT. We have to, during counseling preoperatively, we have to tell them these are the staged procedures. If the educated patients are able to come for the follow-up, we will do under single stage. Otherwise, it has to be staged according to your convenience. We have to use the single word at least. Otherwise, it's a problem. Even in India, the days are changed, sir. Nowadays, everyone having the internet, ChatGPT, and also Perplexity. It's clearly mentioning the procedures and also steps also that. Simply, they are uploading the CT reports also to the ChatGPT. They are asking the question from that. That's why, to save our skins, we in the counseling, whatever you do later on, in the counseling, these are the staged procedures. The first stage, we have to clear the disease. Second stage, inspection. We have to reconstruct later on. Just to save our skins, we have to utter these words in front of the patients. Then what we can do later on.
Side, you are doing two-stage procedures?
For the urban areas, definitely I will do the two-stage procedure. For the rural area, people are even discuss all these much.
One thing, as you said, you have to first of all, before counseling, you have to tell them this is the thing.
Yes, sir. Yes, sir. What I am doing nowadays is I'm asking to come and prepare by reading from the ChatGPT or the Perplexity. I'm giving the homework to them only. The software employees are the very disturbed guys, sir. These generations, Gen Z generations are all very different.
Not only Gen Z, everybody is nowadays asking the GPT what should be done, what is to be done.
Yes, sir. That's why I will give the homework to them only. Right?
So in the counseling, you have to mention that it can be done in two stages.
It has to be done in two stages.
The choice to them.
Not that it can be, because it has to be done in two stages. In the Western world, follow that criteria. But in India, if I say that, I think you will think I don't know the procedure. But you can read out first. Come to me with all the preparation.
So in the counseling, we have to tell them that this point.
Yes. I will ask them to read from the ChatGPT or Perplexity.
Yeah, it's a good.
I will say that.
Take home message that we have to counsel them that this could be done like this. It will be done in like this in US and all. But in India, these are the chances. According to our will, we'll do it.
I will mention and I will record in the case sheet also.
For all these things.
Nowadays, we have kept everything in my room, sir. The room also having the recording facility. It always records everything. We take the recordings afterwards, whatever the required. We have to think it is everything is a medical legal case. That's why you have to counsel in the OP room only. No need for the separate video counseling. My room fitted with the 2 cameras with the audio provisions. We can take from the both angles. We'll save it later on.
Yes, sir. Audio video counseling is a must in these days. And we have to separate book. We have to keep one book. So for all preoperative, because these data will be there for 10 days or 2 weeks in our NR, what you call NVR. So we will ask the patient to, we ask the staff to record it. What time is the counseling done? And that part will be cut and that will be saved to the patient folder. So it is always a good habit. Our senior Rajbabu sir always insists that we should have a proper record. We should have all the patient case sheet along with all the patient reports scanned. So in that you have to keep this consent or counseling video also. You should save that in the system.
Raidu, will they hold any good in the matter of law and other things?
Sir?
Your preoperative counseling videos, will they carry any importance in
Definitely,
the
sir.
court of law?
Previously, why? Because the consent forms are all pre-made. They don't court won't accept any kind of printed matter. If you want to take the consent, AOI also publication has done for all the consent types. We have to rewrite with either the patients or the attendant's own handwriting only in their known language. If no Telugu or English. They have written language only the valid consent for the law, and also AVT video recording also taken as a evidence for the court.
Okay.
And also you have to tell prior recording we are taking the video recording consent. Without consent also against the law.
Achha, you have to record with their consent only.
You have to take the patient's consent while taking this.
That in the local language.
Yes, local language only, and also handwritten consent only. If you take the written form, it has to be on handwritten, and also by the relative of the patient or the patient's own handwriting.
Okay.
What they will say, they made it and ask them to put the signature without reading it. They will easily say that only in the court. If the handwriting matches with them, because they understood, they wrote in their own handwriting. And also wherever, just like Aswadama Hataha, you in the OP room, you can say it. We have recorded everything, and just a single word you have put in that recording.
And the court always sympathizes with the patient.
Always, not only
Always.
court, all
So
the
definitely
society
you have to
against
make
the
our
doctor,
own.
all the society against the doctor, because we have seen now our next generation also has to pay for the penalties.
Okay.
If you die, our children has to face this medical legal funds. Really, the court has given the verdict now. Recent verdict has given like that. Because all the people, the one bridge constructed by the engineer, they won't take anything. Now, so many lives also gone. No one responsible for that. If the dying patient we treat, if dies also, our kids also has to pay for them for the penalty. Or your properties they have to attach to the court. Those are the things are going on.
Okay, sir. Thank you.
Sir, with your permission, we'll go for the next topic. Endoscope assistance in cholesteatoma surgery.
Arun, this is a very
Yes,
nice
sir.
topic because nowadays we have got endoscopic ear surgery, micro ear surgery. People are all getting trained in endoscopic also. But as per my opinion or the seniors, what you say is that when you complement the microscope with endoscope, you will get the better. It's not either total microscope but not total endoscope. Both are the gadgets that were useful for us to clear the disease. So in that matter, let us use both of them as per the requirement, as per the need. Even now also, in all the cholesteatoma cases, at the end of the drilling and all, I'm looking with the endoscope also 0 and 30 degrees. So at any nook and corners, when a cholesteatoma flakes are left, definitely you can clear them better with the endoscope. That I'm practicing nowadays, it's useful for me.
Sir, well said, but
sometimes what cannot be seen by microscope can be seen with the endoscope.
Sir, major surgery done by microscope only. Endoscope is the additional advantage for the supplementary. Why?
That's
Because
what. Let us use that also.
The binocular vision only gives the third dimension. Depth perception only comes through both eyes, not the single eye.
Definitely both. Two are better than one.
By the God in the brain will calculate and give the third dimension is the depth. Depth only comes from the binocular vision. The microscope only gives
Binocular vision.
Binocular vision and also depth perception. In the endoscope, they won't give the depth perception. That's why the otology.
No, only to see any remnant of the cholesteatoma is there in nook and corners.
Yes, sir. Yes. Only.
In the itis, you can look into the itis with the endoscope. Without taking out the bridge, you can look into the itis. You can look into the anterior atic space, into the insertion tube. So all these corners can be examined better by the endoscope, I feel. We'll be doing with microscope only. Take the assistance of endoscope also whenever required.
Yes, sir. There is no fancy things. You shouldn't develop
Yeah.
for 2 years.
So not is totally microscope, not endoscopic. Need not
Yes.
fight with each other. Let us
Yes,
complement
yes.
with each other.
Yes, complement. Those ornaments are there. You can use any of the
Yes.
equipment, but the mainly otologists will
Yes.
develop see the mastoid through the microscope only for the major part.
Final thing is justice to the patient.
Yes, yes, yes. Finally, justice. Yes,
Arun,
sir.
go ahead.
Sir, so the next topic is endoscopic assistance in clearance of cholesteatoma. So the disclaimer is, I'm a micro-ear surgeon and do not hesitate to use endoscope assistance in my surgical practice because my main motto is to improve the surgical outcome. And microscope and endoscope are not two religions; they are our friends. So don't hesitate to take their help for the better outcome of the surgery. So this is about cholesteatoma history. In the management, as we have discussed, so limited cases we can do canal wall up. In recurrence or extensive cases we can do wall down. And so this will be the microscopic ear surgery. It was a must to create a parallel port through the mastoid to gain keyhole access to the attic, but visualization with the microscope was still limited because our view starts from here. Whereas in endoscope, we'll go there and we'll see there. The surgeon cannot visualize the structures directly ahead and is unable to see the objects that are around the corner. Whereas in endoscopic ear surgery, it affords a number of benefits. So probably micro-ear surgeons may not agree with this, but definitely the endoscope passes to this level, and from here with the wide-angle telescope, you'll see the nook and cranny. See, I could see the area that is lateral to this region, but with a microscope, we'll have the vision only like this. And as Raidu sir pointed out, we'll have depth. The depth perception is better with microscope, but telescope we can have angled vision. So what I am suggesting is you can take an angle telescope and take its assistance. So our outcome is, our prime motto is improve the outcome. But there are some limitations with the endoscope. It will be a one-handed technique. One hand will be occupied with holding with the endoscope. But at the same time, some surgeons, they'll do four-handed. One surgeon will hold the telescope and the other surgeon will do the drilling part and the suction. And we also have Dr. Khan's modification of endoscope holder, where he used the endoscope with for doing all the ear surgeries. So just for the completion of the sake, I have kept this topic. So one of the delegates are also asking, so the role of intact canal wall procedure, the basic for any intact canal wall procedure, the concept is that disease is limited. Then only we'll do. But at the same time, you should not leave any epithelial rest in the nooks and corners. That means probably it is in the sinus tympani area or lateral to the pyramid or in the fossa incudis or any bony ledge covering. So all these should be exteriorized. If you can't do exteriorization, you can use an angle telescope and look into the nooks and corners. So what is your comment regarding loop? So I think with the advent of microscopes, there is no point in using a loop. So microscope and assistance with a telescope.
Definitely, there is no use
So
of loop.
in the next video, I will show the how I am complementing how the telescope is complementing the micro ear surgery. Okay, expansion. Please give me 2 minutes. Murthy sir always emphasis on the role of endoscope in micro ear surgeries. So, with his thoughts, I started using telescope whenever I am in doubt. This is one case where I used telescope and see how it is complementing the vision. So, it's an intact canal wall, cortical mastoidectomy done, and TM flap reflected anteriorly. So, I am doing canalplasty. See, I am using suture foil to protect the TM flap. Always the drilling should be drill, suck, drill. So in between you should suck the irrigation so that the field will not be obscured. See, this is the vision with a microscope. There is a lenticular process necrosis. Always look for ossicular continuity. Don't feel that this is a central perforation, you can go easily, you can do a grafting. So if you expose this area and you will see small surprises. Till then, there will be some fibrous band between the making the continuity between the incus and the stapes. So you have to clear all those and establish the continuity. So this is the microscopic image. Within shortly, you'll see. See. So this is the closer image. This is a closer image with an endoscope. Here I am able to see the stapedius tendon closely, pyramid, foot plate. It all depends upon the quality of the telescope which you are using, the camera system, the microscope. So it is always wise to invest on these three instruments for having a good surgical outcome. See, my strokes are parallel to the stapedius tendon. I am going parallel to the crura. So now I am confident that I have not left anything lateral to the pyramid, nothing in the attic, and even into the sinus tympani. See, with endoscopic clearance, now I am switched to microscope. Now I am doing cartilage interposition. This is the remnant incus and this is the head of the stapes. Here I am keeping the posterior cartilage beam, and that is going from the hypotympanum and into the in between the incus and the stapes. This is here cartilage interposition. At the same time, it will prevent the eardrum to get retracted, because this is a case of adhesive otitis media. So this serves two purposes in one go. And this is another piece to prevent further retraction. Finally, I will check how the eardrum is. Even though there is no perforation here, I have grafted, because the eardrum will be thin in adhesive otitis media cases. And now by placing gel foam, I will see that the neo eardrum will be in proper orientation. So you see, in this case, I am clearing the cholesteatoma debris around the stapes. This I am working with a telescope. This much of closer view you don't have with the microscope. And the cholesteatoma is passing in between the crura, all around the stapes. Initially, I thought it's a suprastrix is intact, but slowly after clearing, I recognized that there is no anterior crus. It's only the posterior crus, and the head of the step is supported with a stapedius tendon. Cholesteatoma is hiding in between the posterior crus and the stapedius tendon. So with a gel foam, so gently I am cutting the posterior crus of the posterior crus and the stapedius tendon. It is very tough to break the suprastructure in a case of mobile footplate or mobile stapes. See, this is the final output. This should be the level of clearance. So with the help of a telescope, with the help of cotton ball, or with the help of gel foam, with the help of curved pick, or what do you call this, sickle knife, the final output should be like this.
Sir, one question from the delegate. Sir,
Yes.
do you read perichondrium?
Yes, you can reach the perichondrium.
And the role of tragal cartilage in tympanoplasty in hearing and coach.
So tragus, I don't see any difference between the tragus or tragal cartilage. You can use anything. If you are an endoscopic surgeon, you'll use tragal cartilage. But otherwise, uncle cartilage is easily available for us. See, this is another video where the extension into the sinus tympani. See the use of angled telescope. Dry gel foam moving with a suction tip, or moving with a sickle knife or a curved pick. Will wipe off all the epithelial debris that is there in the any nook and corners of the area. Another thing is you should stabilize the telescope. See, all the epithelial reds are excised. Doesn't matter if you remove some amount of the middle mucosa along with the epithelial, but you should not leave any epithelium behind. This raw area, to prevent Seneca, we'll place some cartilage pieces. So this is the foot plate, this is the round window region. So you are watching everything very closely. And endoscopic assistance in reconstruction. See, this is the closer view you get. So this is the role of endoscope. You take the help, even though I'm a microscope ear surgeon, I take the help of endoscope whenever I am in doubt that some part is not seen.
So there's a delegate asking, sir, can you explain how to place various grafts in various situations? The placement of refurbished ossicle, cartilage, proper top.
And come again.
So the question is, explain how to place various grafts in various situations. The placement of refurbished ossicle, cartilage, PORP, and TORP.
I see, doctor, I don't have any experience with TORP and FORP, but many conferences, even in international conferences, they are saying that they are getting extruded, and in the West also they have started using patient's own or natural ossicles.
Arun,
Sir.
just to share, we asked about the TARP and PARP, and also these are the manufacture and also preparation of the titanium. Anything you have to use interpose between some cartilage or connective tissue, otherwise they will extrude.
Yes, sir. You have to cover them with the cartilage piece. Yes.
Cartilage piece and all, and also make the clearance of the disease, all the middle cavity, any kind of disease also, it causes infection and also extrusion. Is more common with the foreign materials. Better to use the ossicles of the patient's own ossicles or the cartilage or the septal cartilage of the same patient, or otherwise the preserved. If you take the consent, you can use the preserved cartilage also, reconstruct the ossicular chain. Mainly the ossicles are the best material to reconstruct, right? Because that is the metal. Cartilage is a plastic. It gives the real sound transmission only possible with the ossicles. The second grade is the only cartilage.
Yes, sir. So the question is how to place the various cartilage pieces, how to reconstruct various using others. That there are some other videos. We'll address that as we go. Now we are going for a extensive cholesteatoma where we have dealt with inside-out mastoidectomy. And gave T-shaped incision in the post-oral region and post-metotomy. Good morning, friends. This is a case of Sahasra with cholesteatoma with attic defect. After giving infiltration, I started with cornus flap, post-oral vital sensation, harvested the temporalis fascia, and gave T-shaped incision in the post-oral region, and post-metoplasty also done. Now extended canal incisions are being given. Superior flap is trimmed. For the inferior flap is given with a plaster's knife. So let us see whether we can get on with a intact canal wall technique. For this, you can do aticotomy and antrotomy, or you can try inside out canalplasty and find out the sac. You can also do a canalplasty along with aticotomy. I started using a large conical burr for canalplasty. While doing canalplasty, you need not worry about the vertical part of the facial nerve because facial nerve always lies one conical burr size deep. So as long as you are just one conical burr deep, you need not worry about the facial nerve. Small bony bleeds are controlled with a drilling with a diamond burr. I am drilling the scutum to expose the sac and thereby excising the retraction pocket. With a curette, I am gently curating the bony part of the scutum to expose the ossicles. I started doing canalplasty along with aticotomy so that the canal will be uniform and rounded. See, I am using the side of the burr. I am gently delineating the chorda. See, I am checking the depth of the sac by keeping a curved peak like this. So this much of bone overhang is still there. In between, we will assess like this. It is still extending posteriorly. So I decided to do an inside-out mastoidectomy. So I reached beyond the sac and I delineated the tegmen. Now I am regularizing it so that the cavity should be smooth and rounded. In the process of finding the sac extent, I ended up with an inside-out MRM. Now I finished the bony work of the MRM and the sac is completely exposed. As you could see now, there is no incus stapes. I am just seeing only the foot plate. As the sac is completely exteriorized, this sac can be left as the lining for the cavity. I am excising the sac because I don't want to take any chance. Now the TM flap could not accommodate to the widened canal. So I made a slit in the middle so that the flap accommodates to the widened canal.
Also, you should not leave
Cochleostomy sac is being excised.
these bony ridges will leave epithelial remnants medial to them.
Malleus is not skeletonized as the pars tensa is intact. I am now drilling the anterior buttress to expose any sac remnants anteriorly. Now you could see head of the malleus and body of incus attached together occupying in the attic.
This is the small remnant of the body of the incus. See, here I could see the disease clearance in the anterior to the malleus also. That means anteretic. If you can't see what is in the anteretic, you better nibble the head of the malleus. There is a separate instrument called malleus nipper, and you can nip the head of the malleus to get access to the anterior epitympanum. So, as there is no incus in between, there is no role for malleus head for the sound conduction. So, you can as well remove it. So while harvesting conchal cartilages, you should keep in mind what you want and what much of cartilage piece you want. So if you want a cartilage beam, how much? Anterior, posterior, or only anterior? And if you want to reconstruct the scutum, what size is the scutum? If you want to keep the cartilage pieces in the mastoid bowl, if suppose you are operating on a pediatric patient and the muzzle flap is not thick, and if the muzzle bulk is not there for obliteration, you have to take the conchal cartilage pieces for obliterating. So all that you have to keep in mind, and you have to harvest there itself. As I said before, the penna is the chopping board, and you can harvest it, and it is easy to harvest there itself to the desired size. Because once you want to cut them in desired size or the cup, you can't hold it properly. But if here it is already attached to the tissues, so you can design it well.
Big conchal cartilage harvested.
If you want the bulk,
I am designing, reshaping the conchal cartilage so that it exactly fits to the desired dimension of the mastoid ball. I am making the conchal cartilage malleable by making grooves so that it fits to the contour of the mastoid ball. In this case, I am trying to close the mastoid cavity with conchal cartilage piece as if I am closing the cavity with a lid. I am retaining the pericontinement soft tissue and I am keeping it towards the mastoid cavity so that it will fall into the mastoid cavity.
See, this is a limited mastoid cavity.
Long columella osculoplasty has been done, which is covered by the reconstructed cartilage piece. Another two small conchal cartilage pieces are kept covering the anterior part of the attic. So now we have covered the mastoid bowl and also the attic. Now scutum reconstruction is completed. A slit is given in the temporalis fascia, anterior pocket created and double bursting of the graft done. Underlay grafting has been done. Middle ear filled with wet gel foam.
Here what I have done is I have exteriorized the malleus. You may ask, when there is no ossicular continuity, there is no role for malleus. Then what is the point of exteriorizing the malleus? Exteriorize, if you are confident about your skeletonizing of the skeletonizing skills of the malleus, you need not exteriorize the malleus. Malleus will lie medial to the graft. But if you feel you have left some epithelial rest at the tip area like fishtail or near something, so it is better to exteriorize. But at the same time, exteriorizing the malleus will keep the graft close to the promontory. In a case of retractions, it is more chance of getting synechia. So keeping a graft lateral to the malleus is a good option, because anyway malleus is not in continuity and it is not in have any role in the sound conduction because incus is already absent.
Wide metoplasty is done. Finally, a small merocell piece is kept and betadine solution is instilled into it. The merocell swell and reach to the canal size. Thanks for watching.
So, this is about inside out technique for doing wall down procedure in a case of extensive cholesteatoma. For the similar case, I have done with C technique.
Good evening, friends. Greetings from Anjana Vadyalaya. As a part of our online education program, today I am presenting you a modified radical mastoidectomy for a case of CSOM with cholesteatoma. After proper clinical history, you should do preoperative evaluation to identify the disease, know the extent of the disease, and plan the appropriate surgical management. Patient is complaining of right ear discharge on and off. There is also right ear hearing loss, and there is past history of minor ear surgery in the childhood. Video otoscopy showed atic defect with cholesteatoma flakes. Pars tensa is intact. Pure tone audiometry shows conductive hearing loss. As the AB gap is more than 40, we are expecting ossicular erosion. HRCT temporal bone revealed soft tissue densities in the attic and the mastoid cavity, suggestive of cholesteatoma, and there are erosions of the incus and scutum. With this information, let's proceed for the surgery. Our plan is to do a mastoidectomy and tympanoplasty. Given to the preoperative CT scan findings, you can straight away go for modified radical mastoidectomy either by inside out method or a C technique. But if you don't have any preoperative CT scan, you should know whether the disease is limited to the attic or into the mastoid antrum. So for that, you should do a antrotomy first, then decide whether you want to do a intact canal wall or a modified radical mastoidectomy. Cornus flap elevated. Please note the scar in the post-auricular region. This could be a scar of the previous IND in childhood. An IND must be done for a mastoid abscess, which usually indicates underlying cholesteatoma. That means the cholesteatoma has already invaded the mastoid. So you require a modified radical mastoidectomy rather than an intact canal wall mastoidectomy. Post-auricular incision given, flaps elevated, skin flaps undermined. To release the fibrous tissue of the previous scar, we will harvest the temporalis fascia later after confirming the extent of the disease. The triangle of attack, as you all know, is one line along the supramastoid crest, another line along the posterior metal wall, and a line joining these two. And if you go deep inside, you will see the antrum. Don't open the antrum too anteriorly. If you open too anteriorly, if at all the disease is limited and is only in the attic, you can't do aticotomy and canalplasty. So it is wise to open little bit posteriorly so that you will have some bone in between even if you want to do a canalplasty. After seeing cholesteatoma matrix in the mastoid antrum, I decided to go for a
Posteriorly means little bit posteriorly. I'm not saying to open here, but don't open here. There will be lot of bone here in the zygoma. So it is here, if you open, you can go in straightly into the mastoid antrum. And the other thing is, mastoid antrum is a very constant landmark. Is a very constant landmark. If you feel this is a spina fenley, this will be just posterior superior to it. So this part. So always, and the other thing is facial nerve is also very constant. So don't worry about the anomalies of the facial nerve. They come very rarely, maybe 1 in 1,000 or 10,000 cases. But what happens is, because of the disease and because of the cellularity, the proportion and will change. So it may be a contracted mastoid, it may be extensive mastoid. So that relative thing will change, but not the course of the facial nerve. So how constant is the antrum? That constant is the facial nerve course. So all my cases I have seen. So this is the spina fenley. This is the antrum position. Always at the same time, you look for the lateral process of the malleus. See, Lateral process of the malleus is here. That means the tensor tympani fold is medial to it, and this is the process cochleariformis. From here to here, this will be the horizontal facial nerve, and from here to this way, this will be the vertical part of the facial nerve. Even while seeing from this region also, you should be able to look or sketch the course of facial nerve. Then you will be confident whether to do a C technique, inside out, or canalplasty, or even antrotomy.
Wall down procedure. Extended canal incision is given and DM flap is elevated till the annulus. I started with B2B drilling, that is drilling from the anterior buttress to the posterior buttress. I prefer a large conical burr with wide teeth. Facial nerve lies 1 conical burr size deep at the mastoid.
The advantage is with B2B drilling or C technique is we are going lateral to medial. That means you are making a wider cavity before you reach the important structures like ossicles, facial nerve, or even cholesteatoma. So this wide cavity, whenever you are working in a wider cavity, you are at less chance of injuring the structures. Whereas in inside-out mastoidectomy, you start here, you are working in a narrow cramped space. Slowly you are widening it. But here you have already widened it, and slowly you are getting deeper. So in inside-out mastoidectomy, you pass from anterior to posterior or inferior to superior. Whereas in B2B drilling or a C technique, you will start from lateral to medial.
Mastoid tip, and it is even deeper above. So you need not worry about the facial nerve. You can confidently drill whatever the bone that is involved up to 1 conical burr deep. Slowly we have outlined the extent of the cholesteatoma.
See here, once you open it, you have already seen the cholesteatoma. So you know this is the bridge, and this is the ridge. So like I said before, the facial nerve lies 1 conical burr. This is depth of a 1 conical burr size. It is even still deeper. So this much we have already done. We have already removed some part of the bridge and the ridge. So
entire cholesteatoma sac is excised in toto from the mastoid cavity. Simultaneously, we have reduced the ridge, bridge and scutum. Only small amount of bridge is left just lateral to the incus. TM flap is elevated, malleus skeletonized, and at acute notice that the malleus is hypermobile. Hypermobile malleus and ossicular necrosis findings in preoperative CT scan confirm that the ossicular chain is not continuous.
Hypermobile malleus doesn't always indicate a ossicular discontinuity. Sometimes, even if the ossicles are continuous, there may be hypermobile malleus. So beware of that.
So I can conveniently break the bridge. But if you don't have a preoperative CT scan and you don't have any idea about the continuity status, then you better expose the IS joint first. Check whether the ossicular chain is intact or not. If the cholesteatoma sac is lateral to the ossicles, maybe you can get away of clearing the disease with the ossicular chain intact. But if you see that cholesteatoma sac is extending medial to the ossicles or it is engulfing in between the ossicles, it is always better to remove the incus and clear the disease first.
See, please notice the sac medial to the malleus. Is what I am saying. If you notice any sac medial to the ossicles, then there is no second thought, it is a wall down procedure. If the sac wall is lateral to the ossicles, if you are experienced in doing a wall down procedure, you can slowly, gently do a wall down procedure with intact ossicular chain. But by textbook, if you are doing wall down procedure, you have to remove the incus and do the ossiculoplasty later.
Ossicles, it is always better to remove the incus and clear the disease first. Drilling extended anteriorly till the anterior buttress, chorda delineated and preserved.
This is malleus head nib.
Head of the malleus removed. Notice the granular nature of the undersurface of the TM. So this also has to be removed. So I gave a cut in the TM flap and excised the entire pars tensa along with the annulus. This is total annular excision. You could notice the middle ear mucosa is edematous, but there is not much cholesteatoma. Gently, cholesteatoma matrix is dissected around the stapes with a curved peak and an 18 number suction cannula. Fine dissection of the matrix is done with a dry gel foam piece. If we leave a dry gel foam piece on either sides of the stapes, this dry gel foam piece sticks to the cholesteatoma matrix and it clears very easily, and you can see the outline of the stapes very beautifully. So the anterior crest, posterior crest and the stapes are clearly visible now. Now you notice that how much help the gel foam has done for you in clearing the disease around the stapes. Cotton balls soaked in 4% xylocaine and adrenaline are kept in the middle ear to prevent any bleeding while clearing the edematous mucosa over the promontory. Eustachian tubal orifice identified and edematous mucosa cleared. Handle of the malleus also removed after gently clearing it from the chorda. You could notice that chorda, after extending from the malleus, it is exiting from the temporal bone through the canal of Fugere. This clearance in the middle ear and mastoid cavity. Let's proceed for.
Now you are seeing the entire course of the chorda tympani nerve in a temporal bone. This is the exit from the facial canal, passes medial to the malleus head near the malleus neck, and passes from there and exits towards out with the canal of Fugere. So this is the entire course.
Reconstruction. As there is raw area over the promontory, it is our duty to do a cartilage reconstruction to prevent synechia. Wet gel foam pieces soaked in cephaloxity drops are placed in the anterior half of the middle ear, over which anterior cartilage beam is kept. This will function as a support in the anterior wall as there is no annulus. This anterior cartilage beam is strategically placed lateral to the eustachian tubal orifice. So this doesn't come into the way of anterior ventilation pathway. Incision is given in the pinna at the dimple that appears while retracting the pinna. Canal skin is released at the 1 o'clock position so that entire skin will pass on to the mastoid ball as a one flap.
Here you can
Retracting the pinna. Canal skin.
Here you can cut here so that it will give one single flap that will pass from inferior to into the mastoid ball, or you can incise here and so that one superior flap will go in this way and the other flap goes this way. I use this one single flap because from here it will be in continuity, and small single flap will cause blunting in the anterosuperior. So I avoid that flap and I will use one single flap.
Is released at the 1 o'clock position so that entire skin will pass on to the mastoid ball as a one flap. Postoral skin is undermined to expose the postoral muscle, and big muscle mass is harvested to use it for obliterating the mastoid cavity.
So this is how I am fashioning the muscle pedicle graft. This is the T-shape incision, and from here I have cut posteriorly and I have made a slit in between in the middle so that the muscle is lengthened so that it will move into the mastoid ball. So this is the inferior pedicle that will nourish the muscle flap. So this muscle flap, this pedicle should not obstruct the flap coming into the mastoid ball. If it is too anterior, this will prevent the mastoid ball skin to come into the mastoid ball. So also this floor cartilage also inhibits skin flap to fall into the mastoid ball. So floor cartilage is removed and care is taken that the muscle pedicle doesn't obstruct the flap.
This is how I am fashioning the postoral muscle. Conchal cartilage around the margin is cut so that the pinna skin can be rolled inwards to have a good lining for the meatus opening. Big conchal cartilage pieces are also harvested along with the soft tissue to have a good mass for obliteration. Floor cartilage excised so that the posterior canal wall skin falls over the mastoid cavity. This floor cartilage is fashioned and a socket is made to use it as an article and kept over the head of the stapes.
Here, various materials can be used for osteoplasty. It could be body of the incus, it could be head of the malleus, it could be floor cartilage, or even it could be a stored spar cartilage. So this is Napoleon cap, which we keep it over the head of the stapes. As I said before, the size of the burr should be of the size of the 18 section cannula, so that it exactly suits to the head of the stapes. And so you may wonder why this chorda is preserved. One is for taste sensation, and the other is it gives support for the ossicle to stay there. The ossicle has a socket and a supporting wire superiorly.
You can also keep a conchal cartilage piece over the head of the stapes. But my idea of keeping a floor cartilage as a cap over the stapes is to increase the middle ear space, thereby preventing synechia. Cartilage pieces kept in the attic and mastoid cavity. Small cartilage beam is kept in the inferior and posterior inferior place. Big mastoid cavity. Small cartilage beam is.
See here, there is one defect. Here we have updated the attic. This is the posterior bony. This is the facial ridge. This gap is there. This gap is prone for retraction. So whenever I feel any islands, I'll keep one pieces, similar cartilage pieces in this place, so that they will be like satellites around the ossicle. These eventually will stick to the eardrum, neo eardrum, and they will give extra support for the ossicle to stay in place. Mind you, these will not get necrose or these will not fall into the middle ear. They will stick to the neo eardrum.
Kept in the inferior and posterior inferior place. Big temporalis fascia graft is harvested as I have decided for a wall down procedure. Anterior canal wall skin is elevated so that anterior rim is created and tucking is easy. This also lateralizes the TM and increases the middle ear space, thereby preventing synechia. If you are operating under local anesthesia, there might be some pain while elevating the anterior annulus. So it is better to elevate the anterior annulus for creating anterior rim at the time of TM flap elevation itself. Patient may complain of pain if you want to create an anterior rim at the time of grafting. Once you have started grafting means you are sure that you have not left any cholesteatoma matrix within and your drilling is 100% complete. Temporalis fascia graft covers all the middle ear, attic, mastoid cavity, and it also covers the muzzle flap and cartilage pieces that are used to obliterate the cavity. This covering will fasten the healing and the ear becomes dry in just 3 weeks. Dry gel foam pieces are kept on all around the margins. Before closing, gently elevate the temporalis fascia and see whether the ossicle is in place. See here, the ossicle is displaced. So keep the ossicle in position and give a support with chorda. Gently replace the temporalis fascia and keep dry gel foam over it so that there is continuity with the temporalis fascia, ossicle and the stapes. Gel foam tiling is also done to keep.
Because you have done a wide cavity, you don't know, you can't expect through the graft where the ossicle is there. So a lot of maneuvering, lot of manipulation has done. So whether the ossicle is still in place or not, you have to check. And once you check that, see that the graft is touching and draping onto the ossicle. Because if the graft is lateralized and it is not touching the ossicle, there is no fun in doing the ossiculoplasty. So these dry gel foam pieces I am using to press the graft to touch the ossicle.
Keep the TM in orientation and also small pressure over the TM so that it touches the ossicle. Postoral incision is closed. with interrupted mattress sutures. Lampert speculum is kept in the meatus. Big gel foam pieces are kept as a lining. These make the skin flaps stay around the widened margins. Now fill the widened meatus with wet gel foam. Finally place these make.
See, there might be some raw areas here. The external canal skin is here up to this. From here to here, there is deficient because I have released that incision here and the skin is coming from here to here. So this is deficient. This bone should be covered with a temporalis fascia. Even if it is not, then you can cover with a big gel foam piece so that this will be giving a lining to the neo EAC. This I call as gel foam lining. See, you can see one stitch here. This stitch is making the skin roll inside. That means you are covering the brim of the canal with a skin. And here this skin also is coming here and you will make a stitch here so that the metoplasty is secured and it is fixed and it is properly aligned.
Make the skin flaps stay around the widened margins. Now fill the widened meatus with wet gel foam. Finally place a Merocil wick in the EAC and instill with betadine solution. Thanks for watching.
Arun,
Sir. Yes, sir.
this everything is good, but in the osteoplasty, our issue that this cap what are kept on the stapes head will be staying there only without moving. Can we use any? No, can we use any fixing materials like Lysanos? Also, a lot of materials are there. Is anybody using any materials to fix the ossicle or the cartilage or the head of the stapes? Because there is a chance that it could move this way or that way and lose the continuity of the ossicle.
Sir, while doing a socket for ossicle, sir, there will be some bone dust generated. Sir says that will act like bone cement and don't wash it away. So he will leave the bone dust there itself and will keep the reshaped incus over the head of the stapes. That small bone dust.
I use a small bit of fascia also on that and put the cap on that. It will also act as a more anchoring to the underlying stapes along with the bone dust.
Okay, sir.
You can give a small bit of fascia, what is left in the trimming the graft that can be used on the head of the stapes, then put the cap on that. So that will give you more stability than a raw bone and a raw bone.
And we use a fascia for all the foot plates, sir. You used to guide me.
Yeah, same thing you can also irrigate. You can use the same thing here also.
Will it not block?
Will
it not block the socket which we have done with the fascia?
That is a micro fascia, Arun. It's very difficult to trim the size also. You can use the small drop of fibrin glue. Nowadays, Westerns, they are using fibrin glue here and there. In cochlear implants,
that is what I'm asking.
Fibrin glue you can use as a single drop over the head of the stapes. You can attach that one. Otherwise, the cartilage you can make the slit and also you can insert the tensile tendon.
Stapedius tendon.
It has to sit into that glue. It won't mobilize. It fixes easily. But the ossicular issues, you can put a small drop of fibrin glue. Helps more.
Right, you are using fibrin glue?
Sir, other issues in cochlear implants also, sir. Last time Poland, they are using after closing the cavity and all, everything, electrodes, they are doing so much of fibrin glue in the cavity.
Okay.
They are just rolling
glass, I know,
electrode in
some
the posterior wall.
in Mumbai and all.
Sir?
Glass, I know, the small liquids.
Glass, these dental people will use more, sir.
Yeah.
So the hydroxyapatite crystals and also the plates. So many metals are there for dental people.
Also.
Dental people. Yes, sir. Yes, sir.
Yes, sir. With your suggestion, we'll use glass ionomer concentrate GIC and also small temporalis fascia. If the patient is affordable, we can use fibrin glue as the right sir suggested. But the fibrin glue, the TISIL, it is 10,000 rupees. And once we open it, we have to use it.
Yeah, continue.
Yes.
Keep the small quantity of fibrin to over the sides.
There's another question from a delegate. What
Yes.
if all the ossicles are eroded and only the footplate of stapes is seen? How do you do the ossiculoplasty?
See, I have not prepared a presentation for ossiculoplasty, but basically the situations, there are only two situations. There might be 3 or 4 in Austin Cartouche classification, but for me, the ossiculoplasty, it is only two situations, whether it is suprastructure present or absent. The varieties of ossiculoplasty materials may vary. So what we are doing is we are bypassing the malleus. If the incus in between is absent, we are bypassing the malleus. So there is no question whether it is M plus or M minus. So we are doing either platinopexy, myringoplatinopexy or melingostepdiopexy. Only these two situations. So if the suprastructure is present, we'll keep a cartilage piece, conchal cartilage piece, or if you want to maintain the height of the middle ear, you can use a cap, either be it floor cartilage, spur cartilage, or reshaped incus, or reshaped head of the step, reshaped head of the malleus. If the footplate is present and the suprastructure absent,
or tot.
either PARP.
Either partial or total.
Yes, sir.
What's your experience by using the Teflon or titanium, TORP and PORP?
I don't have any personal experience, sir. Raider sir is commenting that while using a TARP or PARP, we should use a sliced cartilage piece over it so that it doesn't come in contact with the graft.
Okay. Hydroxyapatite. Anybody who is using them?
We should have a dental friend, sir.
Or that is Sir Vijayendra sir. All are saying that all these artificial ones will eventually get extruded from the middle ear. So it's always cartilage or the bone or the better than all these things.
Yes, sir.
Arun, continue.
Yes, sir. So till now we have seen the cholesteatoma invading the mastoid bone and widening it, destroying it. Sometimes it is so destroys that it becomes automastoidectomy. So even the cholesteatoma sac is expanding the attic scutum or into the mastoid ball, making it a natural healing mastoid ball. So this is one case where it has become autoepicotomy.
Good morning, friends. I am presenting to you an unedited video of autoepicotomy with ossicular necrosis, where I have done entered canal wall mastoidectomy with scutum reconstruction and ossiculoplasty.
This is the left ear. I am gently delineating the extent of the disease.
Elevating on the interval also.
Yes, sir. Up to the interval. This extended canal incision. This is 12 o'clock. This is 10 o'clock. I'm elevating up to 10 o'clock.
Okay. Can I magnify the video?
Now we can't magnify, sir.
Okay.
Is there any lag, sir, or any disturbance?
No lag, nothing. It's good. One thing is very small.
I think if you are watching in a mobile, you can zoom it, sir.
Okay. Yes, thanks for this. Arun, buy another 2 retractors. Using only one.
Sir? Sir, I use only one retractor, sir, master retractor. I'll take the T incision little bit superiorly so that the need for second retractor is gone.
Feel widening of this canal may cause more retraction, but what I am doing is I am just augmenting and reinforcing the widened canal with cartilage piece that you will see in a while.
We should be able to differentiate between the idiomatous mucosa and the cholesteatoma remnants.
Mastoid antrotomy is done and hiatus patency established.
See, the Yugo fish water test is positive. You are approaching the disease from all the sides. You are clearing from superior, inferior, from the mastoid antrum, and finally you will see the head of the stapes clearly, and then you will dissect the final thing. Care is taken not to injure the chorda. Head of the male is also removed, it is necrosed. So the entire attic is under vision and it is devoid of disease.
Cartilage beam. A long slender cartilage piece.
Here I choose to go for L-shaped strut because this will not only have the stability and this will also prevent the retraction. For this we have to leave perichondrium on one side and we'll cut it so that it will flip and will take the support of the perichondrium on the other side.
Is taken and it is cut on one side, taking care that perichondrium is intact. This will give a short leg which stays on the foot plate and the long leg is spread onto the hypotympanum along the posterior annulus. This will act like posterior cartilage beam.
the height of the middle ear is increased.
This L strut over the vertical strut is this is more secure, and it also functions as a posterior cartilage beam, and you need not worry about the displacement of the cartilage that we place over the foot plate.
This tip should be fashioned so that it exactly fits to the size of the foot plate, and it should be thin, sliced. You have to maintain the nail of the thumb so that that can fix the ossicle or the cartilage piece while reshaping. Now it fitted perfectly. Now we have to reconstruct this scrotum. Sometimes you need to have 2 or 3 trials so that the cartilage exactly fits to the size. Don't be hasty in while reconstructing. Give some time so that is the reconstruction that pays well in long term. Be it hearing or this is dry ear.
Now another cartilage piece is kept for reconstructing the scrotum.
Nice to see Team ENT Kakinada staying together and watching the webinar and giving necessary inputs for the viewers. The other way is you can use a bigger conchal cartilage piece, make it like a comma shape, so that will stick to the scrotum, that will reconstruct the scrotum, and the extension, comma extension will come over the head of the stapes and it will go up to the hypotympanum. So this takes more skill for it to reshape and attain the desired size. Finally, I will close with the gel. There is another video about automastoidectomy. This is only up to the attic. In this video, it will be entire MRM.
Good morning, friends. In this video, I am going to talk about automastoidectomy, where the disease process itself will do the mastoidectomy. Actually, the external canal will be of this size, but the disease has invaded the bone and made it to this present size.
You may ask me, is automastoidectomy is very regular? What is the necessity to do MRM, or what is the necessity for surgery in this case? You may correct, because the mastoid cavity is very regular, but there are some granulation points, some other one or two places, and the patient doesn't have metoplasty. This is then widened canal and the meatus is narrow. So he is having frequent cavity problems. There will be a lot of debris accumulating here, and he is coming to me regularly for cleaning. And the other thing is he is having hearing loss. So my idea of opening this case is to give good metoplasty and excise the granular patches which are there and do an ossiculoplasty so that the patient will be trouble free and happy.
Remove the bony overhang, and this is the cavity that is
just this much of bony overhang is there. Once I remove the bony overhang, this is the entire smooth cavity. That is
we have to look for the ossicular status, and we have to give a drainage, that means a metoplasty. So, and any other remnants. So I am proceeding with the
left ear, attic is here.
structures starting from anterior buttress. So one by one, if you go in a line, you can identify each and everything. So this is the anterior buttress, and below is the interstitial orifice. This is small ridge. Maybe the ossicular remnants are there inside it. And this is the process cochleariformis, horizontal facial nerve, second genu, and from here vertical facial nerve starts. Note the dehiscent vertical part of the facial nerve near the stylomastoid foramen. I'm smoothing the irregular edges and any suspicious areas where small edematous mucosa or any epithelial debris. I'm gently removing them all.
I'm reminding again, this is the left ear. We are drilling over the hypotympani.
This is the head of the malleus, body of the incus. So both together looking like a bony ridge. So after removing these things, we can access to the attic. And slowly, otitis is coming into view. Now I am opening the antrum so that we can complete the inside-out mastoidectomy. So the attic, mastoid antrum and the mastoid cavity all made into one single cavity.
How you understood the reason for doing operating?
I am gently scraping the mucosa in the attic. So here care has to be taken when we approach the horizontal facial nerve, because there could be horizontal facial nerve is dehiscent.
The horizontal facial nerve is dehiscent. Apart from visual acuity, the surgeon should also have the tactile sensation. You should feel
I am gently clearing the mucosa of the footplate and delineating it.
With that tactile sensation, you will know whether the horizontal facial nerve is dehiscent or the bony cover is intact. Because of the granular tissue, mastoid cavity, there is some bony bleed. Keeping eternal cotton ball, reaching hemostasis. The bony bleed as stated.
Muscle pedicle graft to obliterate the mastoid cavity.
Here, the obliteration should not be complete. You should give some widened canal. So you can't obliterate completely, and I don't obliterate completely, so that there will be some widened canal for regular surveillance. For this reason, we do metoplasty. One doctor is asking, is metoplasty required when you are obliterating the mastoid MRM? So my answer is, even though we obliterate, we don't obliterate completely. We'll obliterate only the hidden areas and make the obliteration is, the idea is to make the obliterate the hidden areas and make the neo EAC a smooth rounded one. But definitely it will be bigger than before. So we have to make a metoplasty so that the brim of the axillary canal will be as wide as the canal, so that post-operatively you can visualize, or you can have a good surveillance of the EAC.
Wide metoplasty done.
harvesting of the muzzle flaps is not a big task. It's just fashioning the situation. It can be tailor made. Our idea is to make the muzzle fall into the mastoid bowl. It could be inferior based or posterior based. You can use it depending upon your convenience and preference.
I am using a temporalis fascia piece over the foot plate for giving extra stability for the ossicle to be placed over the foot plate. Reshaped incus is kept over the foot plate. This is also called as long columella or vertical incus.
Arun, any experience with gel filling?
Yes, sir.
Experience with gel filling?
Sir, have you ever used it, sir?
No. That's why I'm asking your experience.
Sir.
Another big cartilage I am keeping in the posterior half of the middle ear. So that is almost coming over to the vertical incus, which I placed over the foot plate.
Slowly I am filling the mastoid bowl with cartilage pieces.
While telling about the previous case, you were telling about a comma-shaped cartilage.
Yes, sir. Yes, sir.
So can you explain that once again?
Yes, sir. That was in case of intact canal wall, sir. This is the scrotum defect.
Yeah.
And from here we have only head of the stapes. So in one of the chapter, Krishnakishore sir has come as a faculty. And I think in chapter 3. So he used a big concave cartilage, reshaped it, one single piece that reconstructed the scrotum, and it is also coming on to the head of the stapes and moving up to the hypotympanum. And he has weakened one or two places so that it will bend.
Okay. So with that kind of cartilage, will there be conduction of sound to the ossicle? Because the total whole part will be like that. So will it be vibrating?
Yes, sir. Yes, sir. You are correct. Ideally in the ossiculoplasty principles, whatever the reshaped ossicular which you are using for ossiculoplasty should not touch any other structure. It should not touch the posterior middle wall or the facial or horizontal facial. I agree, sir. But the stability is also more important at the same time.
Okay.
You can use dry fascia or wet fascia. I reserve the harvesting of the temporalis fascia to the last because
Cavity is filled with cartilage pieces and muscle pedicle grafts.
Depending upon the size of the mastoid bowl.
Foam is placed in the middle ear. Underlay grafting done with the temporalis fascia.
If there are no granulations, you can use the retracted eardrum. You need not excise it. cavity, so I am using a lot of cartilage pieces. Even the floor is also come to very low level. So the external canal floor I am augmenting. This is the left ear, the cutting, and this is the floor. I am augmenting the floor with cartilage pieces, and I am covering with the skin and the temporalis fascia so that there won't be any granulation. Usually for the disease process, we will have widening superiorly. Very rarely we see the extension inferiorly. In such cases,
Thanks for watching.
In such cases, if you don't augment the floor, it will become a blind pit because the entry brim will be at this level. The disease has eroded the floor. So what I have done is I have augmented and I have filled the cartilage pieces in the floor of the external canal so that it is in line with the meatus. Thank you. Any questions, sir? If there are no questions, we'll start with the concepts of metoplasty.
Good evening, friends. In this video, I am showing my metoplasty. Metoplasty is a reconstructive surgical procedure done for the widening of the cartilaginous part of the axillary canal, whereas canaloplasty is a procedure for widening of the bony axillary canal. In metoplasty, we will widen the cartilaginous part of the axillary canal by fashioning the flaps, where the much of the cartilaginous part is not removed. Metoplasty is broadly divided into two types, metoplasty and conchometoplasty. This metoplasty is done as an adjunctive procedure for canaloplasty, intact canal wall mastoidectomy, or modified radical mastoidectomy with or without cavity obliteration. Whereas in conchometoplasty, we will remove a part of the conchal cartilage also to give extra widened axillary canal. The concept of metoplasty is about ventilation. For a good outcome of middle ear surgery or a tympanoplasty, you require ventilation for the middle ear and also ventilation to the axillary canal. If the bony axillary canal is very narrow, that means there will not be much ventilation and there will not be good clearance of the epithelial debris. Such cases, you need to do canaloplasty and if required, a metoplasty. Similarly, in intracanal wall mastoidectomy, if you do a canaloplasty for widening of the bony canal, the axillary canal skins will not line up to the widened axillary canal. So, you need to fashion the skin flaps to hug to the bony axillary canal. This way, metoplasty is required. In modified radical mastoidectomy, you will have a big wide mastoid bowel. If you don't obliterate, you definitely need a conchometoplasty so that you need to inspect, you will have a wide axillary canal and there will be good ventilation so that debris will not be collected in the mastoid cavity.
See, here you see the conchal cartilage pieces, they are sticking to the fascia. This is the postoperative case. This is the anterior cartilage beam. This is this posterior cartilage beams. These are cartilage pieces placed over the attic into the mastoid bowel. All are seen sticking to the graft. They are not falling into the middle ear or causing any granulations.
Even if you do obliteration, the muzzle flap, be it inferior based or posterior based or superior based flap, whatever it is, the muzzle flap will not completely obliterate the mastoid cavity. So it is ideal to refashion the axillary canal skin flaps so that they will align with the widened axillary canal. As I am a micro ear surgeon, I prefer to see the axillary canal with a speculum rather than an endoscope. So I require a wide meatus at the entrance. I am going to show small video clippings of various types of metoplasties. Variations according to the canal size, be it in intact canal wall or in modified radical mastoidectomy. This is a case of tympanoplasty where I have done little bit of canalplasty and I felt that canal is very narrow and the meatus is not adequate. So I wanted to release. So I extended the cornus flap incision at 12 o'clock superiorly, like how you give in the first part of the endoral incision. This will definitely widen the cartilaginous meatus. Again, I am keeping a big gel foam piece as a lining for the raw bone. So this also keeps the skin flaps away from each other. After that gel foam lining, I am keeping the wet gel foam and filling the external artery canal. Small merosil piece kept and betadine or saline is instilled.
This meatus pack will be kept for 2 weeks. So after 2 weeks, I am removing the meatus pack. If you don't do any metoplasty, I'll remove the meatus plaque after 1 week. But if it is a mini metoplasty or a secured metoplasty or wide metoplasty, I'll remove the metoplasty wick after 2 weeks. You can keep it for 3 weeks, but sometimes there might be foul smelling discharge coming from the canal. So I remove it after 2 weeks and fill the external artery canal with Cloben G ointment or Neosporin H ointment.
So that it swells. This merosil wick doesn't displace the flaps. This is a case where a small retraction is there into the attic, for which I have done wide canalplasty and I have to do ossiculoplasty, and now I am reconstructing the scutum. So this is the reshaped incus which I am keeping over the foot plate. A scutum reconstructed by the cartilage.
Till now we have seen various ossiculoplasties also parallelly along with the mastoidectomy techniques. I used reshaped incus over the head of the stapes. I used reshaped incus over the foot plate. I used L-strut cartilage. I used simple cartilage piece over the head of the stapes.
Anterior cartilage beam, posterior cartilage beam and inferior cartilage beam. Grafting is done with temporalis fascia. TM flap is repositioned and a cut is given over the TM flap so that it accommodates to the widened bony canal. See, you are taking so much care to keep the TM flap to accommodate to the bony external artery canal. So it is your duty to see that the meatus is also equally wide at the lateral end, because this laterally is the entry point for the external artery canal. So it is always wise to have a wide external artery canal. So I am doing a small mini metoplasty where I have given a cut vertically 12 o'clock, like how we give over the cornus flap, and further that incision is extended posteriorly to little bit extent, so to the desired extent, so that there will be widened cartilaginous meatus. It is also important to cut it bone deep. If the tissue below the skin is not cut properly, that will have a lot of traction and it will cause stenosis because of fibrosis. So I will take care that I have cut it till the bone deep. I am checking with a speculum. So I will remove the sutures and I will check again posteriorly. See here, I am slicing the skin also, so that this extra tissue will cause widening. This extra tissue may keep the skin come medially into the external artery canal. I am closing the.
Here, as we discussed before, where to suture. If you suture here, this will give extra length for the cornus flap because our incision is here for the T incision. if you suture it medially, the corners flap will be pulled laterally and you will have a gap between the TM flap and the corners flap.
Post-auricular incision in layers.
I generally do 2-layer suturing. For the first reason is we can keep the TM flap and the corners flap in alignment. And the other thing is second stitch here. This will keep the meatus wide. If you don't suture here, the meatus will be collapsing. So I always prefer a wide meatus for my surveillance.
Again, I am suturing the flap to the pinna skin so that it is secured.
You see that this is the free border. This is attached to this region. From here I released and I am suturing to here. That means this much of extra space I have created. This is the basic advancement of the flaps, basic plastic surgery techniques.
These stitches will give us an area of raw area superiorly, so that there are less chances to get it restenosis. Again,
This area I am telling about cutting bone deep. If you don't cut it bone deep, these two raw areas, they tend to reunite because there will be intense fibrous action, and even if you do metoplasty, they will tend to unite. So I have cut it till the bone deep and I will place graft or the gel foam pieces in between so that I will make these two stay away and will not unite.
I will keep big gel foam pieces as a lining. It not only lines the raw bone area of the superior canal wall, but it also keeps the skin flaps in position. So I am filling the canal with wet gel foam, finally placing a small merosil. Initially I used to keep betadine wick. While keeping, it used to disturb the flaps. So after that I started keeping merosil piece. We may be using various materials for obliteration of the mastoid bowl. Bone pate, bone chips, conchal cartilage, tracheal cartilage, musculoperiosteal flaps, fat and fascia. But whatever may be the material, we should not over obliterate. It is always better to under obliterate to have a wide external artery canal. In the course of time, some materials which we used for obliteration may get atrophy and the flaps tend to retract because of fibrosis. So in view of this also, it is always advisable to have a metoplasty so that we can accommodate or we can inspect the canal even after shrinkage. Steps of metoplasty. Retract the pinna and dip the blade at the place of junction of the canal skin and the pinna. So incision is extended superiorly and inferiorly, and it is released from the canal skin superiorly. Any cartilage and any muscle tissue attached to the skin flap is also teased out. Floor cartilage is also excised. This floor cartilage, if excised, will make the flaps stay away. Otherwise, they tend to protrude into the external artery canal. A rim of conchal cartilage is removed so that we will have a skin lining of the meatus. In this case, I am obliterating the mastoid cavity with inferior muscle pedicle grafts, conchal cartilage and bone pad. See, you could see that there is less muscle bulk, so that the muscle flap which I have used for obliteration is only in the medial part of the meatus, and the lateral wall is still wide. So it is advisable to have a metoplasty, so that will give a good view of the interior of the external canal. See, now I am giving a metal stitch in the place where I removed the floor cartilage. This will keep the pinna in orientation, otherwise there will be sagging of the pinna.
This I call it as alignment stitch. So if you don't stitch it here, this pinna will be sagging downwards, and the roof of the canal is at this level and the pinna is at this level. There will be this much of disproportionality. So if you stitch here, and the pinna will be in proper orientation.
So now I am securing the skin flap to the pinna. So all these stitches are to be tailored to the situation. There is no hard and fast and rule, but our concept, our aim is you should have a wide meatus.
These two parts are I am suturing, and this lining is continuous, and from here I interned the margin and sutured one here, one here. So this will be a skin lining, and here also from here to here it will be in alignment with the corner flap and the inferior flap. Our idea is, if you suture like this, even if you don't keep a meatus pack, this meatus will stay like that. So if you are secure like this, you can keep the meatus pack just for 2 weeks. You need not keep it for 3 weeks, or you need not even change it again after 2 weeks or 3 weeks. You need not repack the meatus for meatus closing.
This is a modified radical mastoidectomy done for a pediatric cholesteatoma, where I am planning cavity obliteration with the posterior based muscle pedicle graft. See, here I am also removing a rim of conchal cartilage around the meatus opening, so that to give more extra wide for the external canal. This is called conchometoplasty. This conchal cartilage harvesting should proceed till anteriorly to the anterior wall and inferiorly to the floor. Now I am giving a cut in this canal skin, so that if you suture this will give a lining for the meatus opening. Small release incision. Cutting the small cartilage to give space for the skin to roll over. See, here the inferior flap should be as low as possible. If it rises up, it will close the meatus. And also my concept is not to over obliterate the mastoid cavity. It is better to under obliterate and have a wide meatus at the entry level. I am suturing the pinna skin to the perichondrium inside. See, we got a good lining. And the skin is sutured to the pinna skin.
You are securing the metoplasty at all levels.
This inferior flap also will be sutured to the posterior muscle, to the postauricular muscle. See here, if you remove, after removing the floor cartilage, there will be sagging of the pinna and there will be little bit of orientation mismatch. So to prevent that, I am giving a stitch inferiorly at the region of place where we removed the floor cartilage. This will keep the pinna in good orientation and there will not be any orientation mismatch for the cartilaginous external artery canal and the bony external artery canal. One should be very careful to keep the and take care all precautions to keep the muzzle flaps in position, because in cavity obliteration, if you don't secure the flaps in position, what will happen? These flaps will come onto the external artery canal and will cause stenosis. See here, the medial border of the flap is rising anteriorly. So to keep it in alignment, what I am doing? I am keeping a big gel foam piece in the external artery canal and pressing it posteriorly. These big gel foams, they will cause gel foam lining of the neomeatus. You may think why metoplasty is required when we have already obliterated the mastoid cavity. My answer is we are not completely obliterating the mastoid cavity. We are under obliterating. And also it is equally important to have a wide meatus in the laterally so that you can see what is there inside medially. A small video about revision metoplasty where two different holes are made to unite and keeping a wide meatus.
This has happened because while harvesting the conchal cartilage, the skin is breached. So that when if it not is addressed at this moment, it lateral stage, it will form a hole and it became two meatus center.
Thanks for watching. Please share your valuable comments.
Sir, Murthy sir, Viredi sir, do you want to add anything, sir?
Nothing, Arun. You showed it
Sir,
extraordinarily and all the varieties of metoplasty and the importance of it, and when you are supposed to do it. It's very nice.
Sir. Thank you, sir. Then we'll move to the next topic, cochlear implant and its difficulties. So I included because we are going drilling the mastoid, and there are some situations and where the difficulties are there.
Good morning, friends. In this video, I am showing some difficulty while doing cochlear implantation. In a bilateral profound sensory neural hearing loss, we prefer right-sided cochlear implantation. So I do posterior tympanotomy approach. Let me enumerate the steps before starting for the surgery. So like any other case, betadine painting of the part, local infiltration, sterile draping, post-oral C-shaped incision or a lazy S in extension superiorly depending upon the surgeon's preference, anterior flap and superior based musculoperiosteal flap, cortical mastoidectomy, posterior tympanotomy, exposure of the IS joint round window, curating the round window niche to give a good exposure to the round window, small adrenaline gel foam around the round window, and starting the preparation of implant bed or the parietal bone. Also creating a channel for the electrode to pass through the cortical mastoidectomy, posterior tympanotomy window and into the round window. I do round window insertion. This completes the main part. After completing the round window insertion, we will go for NRT, check whether all the electrodes are inside the cochlea. Then posterior tympanotomy and round window sealing. I do tight periosteal pocket for keeping the implant. Some may prefer tie-down holes for securing the implant. Finally, closure in layers. While drilling, there are certain difficulties in cochlear implantation. There could be a thin parietal bone if the kid is less than 3 years. There could be forward sigmoid sinus, low-lying dura, making a contracted mastoid difficulty for inserting the electrode. There could be narrow facial recess, making the view of the round window niche difficult. There could be posterior rotation of cochlea, making it even more difficult for exposing the round window niche. There could be a emissary vein which might bleed while elevating the posterior musculoperiosteal flap. And there could be marrow bone in the mastoid. In the preoperative evaluation with the CT scan, we found anterior placed sigmoid sinus. So let us see how we can get away with it. Let's start the surgery. After giving a infiltration, post-oral C-shaped incision.
So in routine mastoidectomy, we'll open the meatus. So we'll have the exploratory canal and we'll know the landmarks of the spina fenley and others. But here in cochlear implantation, we don't open the external canal. For that, what we'll do is, we'll take a pericontal elevator and gently elevate the skin here, and we'll first define the external canal. So then you will know the spina fenley, and then posterior superior to it will be the mastoid antrum. So, but here the sigmoid sign is too anterior that it is almost nearer to the postmedial wall. But we have to keep the electrode. We will place the external implant here, and the electrode should fall into this mastoid cavity. But there is no place. So let's see how we manage this case.
Anterior flap raised, superior based musculoperiosteal flap raised, cortical mastoid bone exposed, cortical mastoidectomy started, and we could find sigmoid sinus anteriorly. We notice anteriorly placed sigmoid sinus all through the length of the mastoid bone from the tegment till the mastoid tip. So it's a challenge for us to make a space and identify the antrum, short pulse of the incus. I am drilling anterosuperiorly, making my way towards the adhesive. Thinning the posterior medial wall like bone china will give us some space. Antrum gently widened to identify the short process of the incus. There should be a coordination with the drilling, suction and irrigation.
Slowly we are gaining space. Initially we thought we don't have any space. Slowly we are gaining space. Here our direction of drilling should be, the burr bit should be parallel to the EAC curvature. Otherwise you will enter the external canal. The next step is identification of the short
For identifying the short process, leave a small bit of bone like that is incus buttress, and from there you start drilling just above the vertical part of the facial nerve. See that your burr is parallel to the posterior meatal wall so that it doesn't enter the axillary canal. Before starting the surgery, we put some bit.
See, you could identify the incus here. This short process of the incus is a facial nerve pointer. Medial to it will be the second genome. So the incus facial nerve is coming like this, second genome, and it is passing like this. So I know the anterior limit. This will be the annulus, and this is the posterior limit, facial nerve. So I will drill in between so that to gain access to the round window. Probably this could be a chorda tympani nerve. So the facial nerve is lying medial to the incus pointer. So this is the reason why we expose the till the we see the short process of the incus.
In the axillary canal, so that if any unknowingly if you enter the axillary canal, any betadine stain into the mastoid cavity indicates that we accidentally entered axillary canal. While doing posterior tympanotomy, our challenges are posteriorly we have facial nerve, anteriorly we have annulus or the axillary canal skin. So our trajectory should be in between. If the facial recess is very narrow, you may need to expose the facial nerve to give some way to find the round window niche. Slowly round window niche, IS joint, pyramid came into view. Now you could see the round window membrane deep in the round window niche. The round window is not clearly seen. You may need to drill the operculum so that round window is clearly seen. Put some adrenaline soaked gel foam in the middle ear to deal with any small mucosal bleeds. Now let's start making the implant bed in the temporal bone. For that we have to identify the temporoparietal suture, and the implant bed should be behind the temporoparietal suture line. So this will give a good length for the electrode. Otherwise too much of electrode will be coiling in the mastoid cortex. Also parietal bone is flat, it can accommodate the implant. Kirtane sir has designed a retractor to help us having a good visibility or the parietal bone. With the metal template, we make the outline and we drill in between to make the implant bed. In young kids, roughly between 1.
This is the temporoparietal line suture. So our implant bed is lateral to the or posterior to the temporoparietal suture line.
1 to 3 years, they have thin parietal bone, and it is a challenge for us to create the bed as the parietal cortex is very thin. The shape of the implant bed varies with the company and model of the implant. Now a channel is made from the implant bed to the mastoid bowl. I usually make a tunnel for the electrode to pass into the mastoid bowl so that the electrode will not come out. But here I am unable to make the tunnel because the sigmoid sign is not only anterior, it is also superficial. So I made a curvilinear channel for the electrode to enter into the mastoid bowl.
Usually the electrode will pass like this to this, but here I made it curvilinear and the channel is going from the above. The channel should come from here so that the electrode will pass like this. But because I have sigmoid sinus here, so I made a curvilinear channel so that the electrode array is entering from this region.
Small operculum over the round window niche drilled with a hand burr.
You can use a skater for this purpose. Decatron is instilled. before passing the electrode array into the cochlea. Implant is placed in the bed and electrode is passed through the round window into the cochlea with the help of Jewell's forceps. And this is Jewell forceps. It will have a groove in it so that to hold the electrode array without any compression. This is another special instrument called claw. It will have two prongs like thing so that it will guide the electrode array into the desired trajectory. And a claw is helping us in guiding the electrode into the round window. While passing the electrode into the round window, we are placing the electrode into the sinus tympani of the cochlea. The insertion of the electrode should be very gentle and it should be very fast. Insertion may cause turbulence in the cochlea. The electrode is inserted till the knob. This ensures that all the electrodes are in, but this should be confirmed with NRT. The specially designed Jewell forceps will have a groove in it so that there will not be any undue pressure over the electrode while holding it. Also, we'll hold the electrode proximal to the knob. The excess electrode array is coiled in the mastoid bowl and the loop is made in the mastoid adhesive below the incus. Round window is sealed with muscle tissue and also surgicel. Similarly, muzzle plug and surgicel are kept around the post-tympanotomy window. Mastoid bowl is filled with big dry gel foam piece securing the electrode. Small muzzle pieces, bone pate and surgicel are used to seal around the implant in the implant bed, also around the electrode channel in the channel provided for it. This is the channel for electrode array. Bone dust is placed over the exposed sigmoid sinus. For all cases, it is a routine for me to collect bone pate at the starting of the surgery itself. After checking the electrode position with impedance and NRT, the incisions are closed in layers. This bone dust will later ossify caused by. Thanks for watching. Another difficulty is enlarged vestibular aqueduct. Good morning friends. In this video, I am going to show difficulties in cochlear implantation. As a part of preoperative evaluation, we have done HRCT temporal bone and MRI temporal bone, which revealed enlarged vestibular aqueduct, but the cochlea and other structures are normal. We expect a perilymph gusher or a oozer in this case, so we need to plug the electrode tightly. So for this, special Form 24 electrode is ordered, which comes with a stopper that snugly fits to the round window niche. Post-auricular C-shaped incision given, skin flap and anterior muscle flap elevated, posterior superior based musculoperiosteal flap elevated, Kirtanese retractor applied, musculoperiosteal pocket made, temporoparietal suture line identified. Metal template is taken and markings made for the implant bed and implant bed created. A channel for the passage of electrode array into the mastoid bowl also made. External aortic canal delineated by elevating the external aortic canal skin. This marks a landmark for the next cortical mastoidectomy. Banana shaped cortical mastoidectomy done. Antrum widened anteriorly towards the zygoma to identify the
short process of the incus. This short process of incus will be our facial nerve pointer. Axillary canal bone is thinned. Care has to be taken not to breach the axillary canal or not to injure the annulus. Now drilling started in the facial recess region, leaving a small strut of bone inferior to the short process of the incus. This is incus buttress. The drilling goes parallel to the axillary canal so that we don't injure the.
This is the bridge I am referring before. The electrode channel will pass into the mastoid ball, this leaving a small bridge over it. This will not allow the electrode to come out.
Annulus anteriorly and the facial nerve posteriorly. After entering into the middle ear, we will expose the stapedius tendon, IS joint and the round window niche. In this case, the cochlea is posteriorly rotated, so round window niche could not be seen clearly. So I had to expose the facial nerve.
So somebody asked where to when
Bony
to
overhang is drilled with a 0.7 mm cochleostomy bar, but it is to be done with very slow speed.
So this cochleostomy or drilling over the operculum has to be done with low speed. In this region, in these areas, we better use a brushless micromotor that stops immediately when you release the foot control. So Surgic AP brushless micromotor, it works well. So I'm using that at low rotations. You can use a skater also at this moment, but a skater is little bit expensive.
Round window along with the annulus is completely visible. You could also appreciate the bulging of the round window membrane. Round window membrane is gently elevated from the annulus and you could see perilymph leaking through the round window into the middle ear. This is perilymph oozer. Head end of the table is elevated and we waited for the perilymph to come down. Excess perilymph in the middle ear is gently sucked.
You could see the pulsations. Once the perilymph has come down, this is the new Form 24 electrode. This is the knob specially made so that it blocks the round window.
Now, gently electrode array is passed through the round window with the help of Jewell's forceps and a claw.
Electrode array will take its own course along the spirals of the cochlea. What you need to do is just gently negotiate it. You need not push it. This should be a smooth insertion and slow insertion. You could notice that the knob is a little bit bigger than the regular standard electrode array. So I am giving tight seal with Surgicel, perichondrium, periosteum, muzzle, so that it will not.
Perichondrium, periosteum and muzzle can be used to pack around the knob for getting a good seal. Surgicel is also packed around it to prevent any leak. The electrode array is curled and is placed into the mastoid adhesive below the incus. Thanks for watching.
Good afternoon, Arun.
Sir.
Here, you have described the two scenarios. After observing the two scenarios, these are not the difficulties because the preoperative planning is very much important for the juniors.
Yes.
I'm saying
Yes, sir.
preoperatively HRCT, how to study HRCT in a proper way. That is the roadmap for the surgery to get the better outcomes. Here in the first case, the anterior placed sigmoid sinus, but there is enough space for the Sinus is difficult. But in this type of scenarios, we can change the procedure after seeing the CT scans. That is
Yes,
called a supramastoid or the transcanal. The Vary approach is better for these kind of surgeries.
yes,
You
sir.
can change the surgical technique prior the surgery also after seeing the CT scans. The second is we have to make the trajectory and visual axis is our key to identify the round window. If you observe
Yes, sir.
the CT scans in the axial or coronal cuts, you can make out the visual pathway, visual trajectory for the round window niche. Here, what
Yes,
happened?
sir.
You have reduced the facial nerve some more and more. Instead of reducing the facial nerve, you can make the posterior bony canal wall very thin, and also it can be fractured out. You can take it out and replace it later. Or
Yes,
you
sir.
can
Yes.
push with the Freed's elevator to push anteriorly and also rotate the head towards you. It gives the
Yes.
better access to the round window niche. These
Yes,
are
sir.
the two things can be taken and can be modified to overcome these difficulties. And also, third most point, what the type of electrode you have used, those are called the form electrodes. These are specially made by the metal company only. In that, what
Yes, sir.
happens, the marker made like a cork. In the wine bottle cork, you can see the shape is the conical. The conical
Yes.
shape part completely seals the round window niche to prevent the perilymph gush. There, some types of electrodes won't not there. Then we can make a small soft tissue window. We can keep it and fully first load prior to the insertion. We can snugly fit into the round window niche. These can be prevented like that. That's why the preoperative planning is very much important. We should not rush for to do the surgeries. We have to understand anatomy and radiology properly to do the surgery. And also, in the second case, you push the electrode, it has so many angulations, has taken so many directions. It causes so much intracochlear issues later on. We can't predict
Turbulence.
now, not predict now, because the fluid things also it's roughens the basilar membrane. Sometimes the fractures the spiral laminas and also the shelfy bone like things. Later the patient will have the speech discrimination issues later on. He may hear properly, but the speech development, speech discrimination is difficult for these kind of patients whenever the more intracochlear trauma happens. That's why everyone is thinking about keeping the electrodes inside the cochlea. Not only the goal, the soft tissue techniques. Soft tissue techniques are the more important
Insertion.
things. We shouldn't create more trauma to the bony labyrinth also. It causes so much inflammation. It causes fibrosis and ossification later on. We have to predict the lesions also. What happens to the kid, we don't know. Sometimes the trauma, soft failures, hard failures, so many things happen. So we may be able to revise the surgeries also. That's why we have to maintain the cochlear anatomy physiology as much as full as intact. Those are the things to be taken care of while doing the cochlear implant surgery. Okay, but good. You have overcome the both of the issues very well. Very nicely done. Good, very good. Thank you.
Yes, sir. Thank you, sir. There is one question. How many cases of labyrinthitis ossificans and what approach taken by you, sir? Sir, I think this question will be better answered by Subbareddy, sir, being a senior cochlear implant surgeon. Sir, can you take this question, sir?
What one? What the
How
question?
to about labyrinthitis ossificans and what approach you will take?
In cochlear implantation or routine you're asking? In the cochlear implantation,
In
always
cochlear implantation. Yes, sir.
always you have to follow the soft tissue, soft surgery skills, soft surgery technique. You shouldn't drill more with the fast. You have to, if you want to use, you have to reduce the speed of the burr as below as possible, around 800 revolutions per minute only. Only some of the drills only gives that much revolutions. And also, whenever needed, you have to use the bony overhangs only. And also, while doing, you can use the decadron, preoperative decadron injections, or intraoperative also. You can flush with the decadron instead of the saline. And also, incision over the round window membrane only. If only needed, only we have to do the marginal cochleostomies or the cochleostomies. This can prevent the inflammation of the bony labyrinth.
Yes,
Okay.
labyrinthitis ossificans. Yes, sir. Labyrinthitis ossificans can occur post meningitis. So, if if you are suspect labyrinthitis ossificans, you have to do MRI and CT scan of the cochlea, so that if it is patent, sir, any experience about dummy electrode insertion, sir?
That is okay. That is called the auto-neurological emergency. Whenever the patient child have the meningitis, it definitely leads to the ossification. We have to assess while post-traumatically or meningitis also, we have to follow the kid within a month. We have to reassess and we have to plan for the implantation. If the patient condition is not good, then we can ask the companies to provide a dummy electrode. Just like an implant surgery, we can make it and we can keep it in the labyrinth. Otherwise, totally ossified, we cannot put the electrode into the cochlea. Previously, they used to supply two-channel electrodes, but nowadays not available. That's why that is meningitis leading to hearing loss is the auto-neurological emergency. We have to aware about it and also inform the patients what happens in the future. That's why you have to make prepared to do the cochlear implantation as early as possible after having the patient's condition stabilized. Otherwise, we have to keep at least the dummy electrode, what Arun said. Like that, we have to keep the dummy electrode in the cochlea.
Yes, sir. Depending upon the level of, sir, Ramana, sir. Sir, you are online, sir. And depending
Arun,
upon
overdose already is so one day I taught so many things. It's very difficult to understand and memorize the juniors. Okay. It's very good scientific feast today. I think gradually the participants are dropping down.
Sir. Last one more thing is there.
One more thing. It's very difficult for them, Arun. We have key features and close the session. It's better.
Yes, yes, sir. Yes, sir. Yes, sir.
Okay,
We're almost done. Sir, one video about Atresia. Sir, Ramana, sir.
Yes, I'm hearing you. Right.
Sir,
From
thank you, sir.
Excellent demonstration.
Sir.
I'm in Bombay now.
Yes, sir. Yes, sir.
But I'm closely following your demonstrations.
Sir.
Very good sessions from Subbarayadu.
Dear friends, in this video,
regarding this cochleostomy, in case of labyrinthitis ossificans, if this is totally theory, I don't have much experience. If the basal turn is ossified, you need to do second turn cochleostomy. So I have done recently cadaver dissection. So I am showing one small video clipping.
I am showing the cadaver dissection of cochlea. As you all know, the basal turn is towards inferior and the apex is towards the above. You are seeing the promontory through the facial recess. In cochlear implant surgery, we insert the electrodes through the round window. Some prefer cochleostomy. Now you can see the round window. Anteroinferior to the round window, we will do the cochleostomy. In cases where you are unable to expose the round window, you can do cochleostomy and insert the electrodes. Either in round window or cochleostomy, we will insert the electrodes into the scala tympani of the cochlea. In cases cochlea is ossified, you have to do insertion of the electrode through the second turn of the cochlea. For that, you have to do a cochleostomy anteroinferior to the oval window. For doing this, you have to remove the incus buttress and also the incus. See, this is the stapes. Now I am pressing and you could see the round window reflex. We have to make fenestra anteroinferior to the oval window or the stapes for electrode insertion to the second turn. Just inferior to the process cochlear formis is the area for apical turn. See, this is the cochleostomy done in the apical turn. As this is a cadaver, I am doing washing. So by washing, you could see that water is freely flowing in all the turns. That means all these are in continuity. Now I am passing the electrode through the cochleostomy. You could appreciate that the electrode is passing along the basal turn and it is coming into the second turn.
So hope this answers the question about labyrinthitis ossificans. If you can't do basal turn insertion, you can do a second turn insertion. But as whatever we have done, these are only basic situations. There are very difficult situations later that not in this session. Maybe senior Raidu sir can do in a separate stage. So the last topic is atresioplasty. Where external canal is totally bony atresia is there. So I have created external canal. So this is the microscopic picture, and the bone is totally atresia. You are seeing a small dimple, but it's not opened. For anywhere, the external canal is the identification for is the landmark for the mastoid antrum. But here we don't have that external canal landmark. So here we are creating the landmarks. So by opening the mastoid antrum. Now I am creating the external canal by removing the atretic plate. This is acquired external canal atresia. So I am not expecting any abnormalities of the facial nerve. If it is congenital, probably there may be anomalies of the facial nerve. So you need to be very vigilant while drilling in the external canal. So there is small cholesteatoma. So that indicates that the external canal atresia has left epithelial rest medial to it, which later turned into cholesteatoma. So I have done episiotomy along with the canaloplasty. So once a small opening is there, then from there it is easy. First opening is difficult. After that, it is a cakewalk like any other canaloplasty and episiotomy.
What are the CT findings, Arun?
Sir?
What are the CT findings in this case?
CT findings, the canal is atretic, sir. Bony canal. So in CT, we'll know whether it is external canal soft tissue atresia or bony atresia. There is bony atresia and cholesteatoma debris inside, and ossicular necrosis is also there, sir.
So can you give hearing? The cochlea is okay?
Yes, sir. But here, if this is a old lady. So our thing is to give a external canal so that she can use a hearing aid.
They might be moving.
Sir?
Even if the oscles are there, they will be fixed and not moving. In this type of cases.
External canal atresia, sir. Oscles might be mobile.
Arun?
Sir.
Arun?
Sir.
How do you say this is acquired atresia?
Sir, just because that she used to have a canal by history, sir. One. The second thing is we are having a canal actually cholesteatoma medial to it.
Okay, even the congenital can have, no? Congenital can also have epithelial remnants.
Yes, sir. Yes, sir.
Sir, if only hearing was the primary goal, why not try
Because the total atresia, will there be any inequities?
Sir, she is a very poor lady. I have done this for free.
Oh, no, not, I'm asking.
No, not like
How
that.
can you say that is equate?
Saha is a very far beyond reality for many. Here, the challenge is not just creation of the external canal. Our challenge is also create the external canal skin, because there is no external canal skin. For this, we have to take a split thickness skin graft and use it for lining. So she is an old lady and she is not willing for consent for this split thickness graft harvesting over the thigh. So I harvested a big temporalis fascia. I refashioned it like a carton box and kept it covering as a external canal skin, eardrum, till the entire length of the external canal.
Arun, it won't serve well. I think graft only won't serve. See how to put the skin graft. You can easily harvest from the post-auricular incision. You can harvest from there itself. No need for the thigh area to cover the external canal.
You can harvest with a blade, sir, or Humvees knife, sir.
You can harvest. You can take some more incision parallel to the external canal. Whatever you give on the Weil's incision, it depends upon the 2 to 3 mm or 4 mm or 5 mm. Back to the same incision, you can give the small incision, elevate the skin from there. You can medially, you can the thickness you have to decrease. That is split skin graft. It can be used as that graft.
Yes. Yes.
An easier way to do the same incision site. No need for the other place. We have to keep the skin. Otherwise, it has to have so many problems later on for the canal issues. Unless the squamous epithelium covers the canal, it takes so many issues later on. Even though you can beautifully place this graft also, but there the protective area is the only squamous epithelium only has to cover the external aortic canal bone.
Yes, sir. Yes, sir. Even in the post-operative period also, this look more white. It doesn't have the normal color of the skin. As you said, I should have taken the post-operative split thickness graft so that that will give good color also.
The same incision site you can harvest easily. You can make it thin by medially. You can reduce with the new blade. The very thin grafts you can make it easily.
Yes, sir. This wide metoplasty I am securing so that even in normal metoplasty also they tend to close, but this is a case of atresioplasty. I need to be doubly sure and I don't want to take any risk for the meatus to collapse. This is the post-operative picture after 1 month. Slowly the graft is taking up. This is after 6 months. So now we have given some external canal so that the patient can use a hearing aid.
Arun,
Sir.
hope it's complete. You have given us an idea
Yes, sir.
about everything in the ear and the mastoid, including the simple mastoid. Still something is there.
Sir, this is the recent emergence of malignant artery section. So I think a small mention about this, sir. This will complete the today's webinar from my side. So we'll see a typical granulations at the floor at the entry of the external artery canal. This is very characteristic for malignant artery section. So uncontrolled diabetes, patient complaining of severe pain, ear discharge not responding to regular medication. So you don't hesitate to take the culture sensitivity swab, and at the same time you can also take a biopsy. These granulations are probably entering from the stylomastoid foramen through the fissures of Santorini in the external artery canal. So in my limited experience, I can't talk much about this big emerging topic, but here this patient is having facial nerve paralysis and he came to me. So I have done wall down procedure and see this is the facial nerve I exposed. I am drilling towards the mastoid tip. I am cutting the tip and going and exposing the facial nerve. In malignant artery section, I observed two trajectories. One towards the facial nerve in the stylomastoid foramen. The other is towards the petrous apex, to the anterior protimpanum. So in those cases, the disease will be uncasing around the external artery canal, and it is very difficult. So probably we should refer those cases to higher centers. But if it is going towards the facial nerve, mastoid tip, stylomastoid foramen, we can do a good decompression and we can relieve the patient of severe pain. So like I said before, the major part will be with a diamond cutting burr, and once we reach the vital structures like facial nerve, we'll go with a diamond burr, leaving a small eggshell bone, and after that, that eggshell bone will be removed with a curette. See, the lower vertical part of the facial nerve is exposed. There are no fixed guidelines for the management of the malignant artery section or skull-base osteomyelitis because the treatment protocol is still emerging. Early identification is the key, and you can give Magnex, Piptaz, Meropenem, Mero-SB. Once the disease is under control, you can switch on to Garinoxin, Genox tablets, maybe 2 weeks or 3 weeks or even 6 months. If the patient is not comfortable and still complaining of pain, CT temporal bone and most importantly MRI temporal bone will give more detail about the soft tissue, inflammation and infection and involvement of the facial nerve. See, I am going more towards the mastoid tip. I am slowly clearing the granulations around the facial nerve at the stylomastoid foramen. Facial nerve decompression is also a very good rewarding surgery. The patient will have good eye closure immediately after surgery, and it's a I am removing granulations medial to the facial nerve. I'm reminding, usually we'll stop at this level. From here to this level, I have done the drilling of the tip. Usually our mastoid bowl will be in this region. This region will never go. See, this is a very rewarding. So with this, I'm concluding my topics. So all about mastoids, from basic cortical mastoidectomy to extensive diseases like malignant otitis sectiona and latest advancements like implantology in cochlear implant.
Congrats, sir. You have covered
Everything, nothing is left.
radiology. Nothing left. Congratulations. Very well.
Thank you,
Very
sir.
well.
Thank you.
Very good. But difficult to stay on Sunday from 9 to 2 o'clock.
Thank you. We appreciate the effort, your hard work. Very much.
Sir, after an exhausting academic event, we all require a wonderful lunch.
Hello.
Good job. Good job.
Sir.
Hello, Arun.
Sir. SK, sir. Good morning, good afternoon, sir.
Good. Nice to hear.
In spite of your busy schedule, you could make it today, sir.
So, it's good to see this type of activity and interaction is very important rather than the workshops and all. That's a different phenomena. One-to-one discussion will be there in these type of interaction sessions, and really hearty congratulations for you, Arun, for the wonderful job you are doing. Regarding the skull-based osteomyelitis, protocol is coming within 6 weeks.
Sir.
So already national body has formed a team to form this particular point. So
yes, sir.
And vertigo also, we're coming with the 2 protocols. And the next Bombay conference will have a printout of both.
So in ISOCON, we'll be able to have that, sir.
And regarding the malignant otitis sectiona, it's more of antero-inferior disease of the temporal bone rather than mastoid. Mastoid usually won't be affected much in malignant otitis sectiona. It's more of towards petrous, towards East-Asian tube and all this matters. And the role of antibiotic and medical line treatment is definitely has got a more important role than surgical role. We should not jump onto the surgery immediately. Wait for some time, 6 weeks. Then only we go. Okay, all the best, man. Thank you.
Sir, thank you, sir. Thank you, sir.
Good to hear
Have been
about
regularly encouraging me. So I should thank all the seniors who have attended and who are giving inputs at the appropriate moment. I thank AYAP President Dr. JP Reddy sir for allowing us to do this webinar. Secretary Rakesh sir for helping and guiding me, and especially Sahasra ENT Foundation, Dr. Sriharsha for making this webinar happen. So Sriharsha has been instrumental since COVID times. For regularly, he is conducting these webinars and imparting knowledge for all the ENT fraternity. So thank you, Sriharsha.
He has become very popular in
Thank you, sir.
conducting workshops and conferences, Harsha.
Thank you, sir.
He is
Nice. I had the opportunity to demonstrate it from his hospital also in Telangana State Conference in the Cochleostomy.
Oh, yes, sir.
Last year. Nice. So all younger generation are leading to uplift the specialty. That's very important. We have to create a good platform to make honor of specialty. Thank you, Anan.
Good to hear you, Paro.
Sir, Arun garu, namaste, sir.
Good to hear your voice.
Sir.
Very good sessions and also. Yes.
Sir. How many people are coming for the next week workshops? 2 workshops in Hyderabad. One is pediatric and OSA issue. The second one is skull base, 360 degree skull base in Apollo Hospital. Those interested in lateral skull base, please attend that function. But that workshop is very useful. Okay. Good case are there.
Yes, sir.
Okay.
Right, Dr. Arun, congratulations. Sir.
Thank you, sir. Thank you, sir. All with your blessings.
Wonderful job. I'm very happy.